All right. We have plenty of abstract, interesting one to start our general session. The first talk will be about the circulating tumor DNA surveillance in ZEST. It is a randomized phase 3 double-blind study of niraparib or placebo in patients with triple negative or HER2 positive BRCA-mutated breast cancer with MRD after definitive treatment. The speaker is Nick Turner from Ralph Lauren Center for Breast Cancer Research in London. The floor is yours.
Well, thank you very much for the introduction. It's a pleasure on behalf of my co-authors to present this abstract on circulating tumor DNA surveillance in the ZEST trial. Here are my disclosures. Following treatment for early-stage breast cancer, 20 to 30% of patients will later relapse. There is no standard of care available to detect molecular residual disease and direct further therapy to prevent or defer relapse. ctDNA testing in plasma may identify MRD that persists after completion of definitive therapy, with ctDNA detection associated with a very high risk of future relapse. Niraparib is a highly selective PARP inhibitor licensed for the treatment of ovarian cancer, and we know that approximately 60% of triple-negative breast cancers have underlying homologous recombination repair deficiency. So ZEST was a phase 3 randomized double-blind clinical trial of MRD-directed therapy in breast cancer, aiming to assess whether niraparib could improve disease-free survival in patients who had completed treatment but had ctDNA detection with no evidence of radiographic recurrence. So the trial recruited stage 1 to 3 breast cancer, triple-negative breast cancer regardless of BRCA status, or hormone receptor-positive breast cancer with tumor BRCA. And here, tumor BRCA implies BRCA testing on the tumor that will pick up both germline and somatic BRCA mutations. Patients had completed standard therapy with curative intent, although hormone receptor-positive patients were allowed adjuvant endocrine therapy and triple-negative were allowed adjuvant pembrolizumab for ctDNA surveillance. There were no clinical signs of recurrence, and I just also highlight that patients who had had neoadjuvant chemotherapy and had no clinical response were excluded. Patients had serial ctDNA testing to monitor for MRD. Those patients who had ctDNA detected had staging scans, and those patients who had recurred were off study. And then patients were randomized in 2 cohorts. Cohort 1 was for tumor BRCA mutant breast cancer, and cohort 2 was for triple negative who were wild type for BRCA mutations, and patients were randomized 1-to-1 between niraparib and placebo. Initially, disease-free survival was the primary endpoint, but this was changed to safety and tolerability of niraparib when enrollment stopped, and recurrence-free interval was also assessed. So a personalized tumor-informed ctDNA assay was designed based on whole exome sequencing of the tumor and matched blood, tracking 16 mutations per patient. ctDNA surveillance was conducted every 2 to 3 months, and the aim was to enroll sufficient patients into ctDNA surveillance to randomize 200 patients in cohort 1 and 600 in cohort 2, and for completeness, I show you the statistical design here, although study enrollment was terminated after 1,900 patients were recruited and only 40 randomized. So, 1,900 patients entered ctDNA surveillance, and of those, 147 became ctDNA detected, so 8% of those who entered surveillance. Only 4 patients recurred despite being ctDNA negative, showing a very high sensitivity of ctDNA testing for future relapse. Of the patients who were ctDNA detected, 50% had a radiologic recurrence at the time they were ctDNA detected, and in addition, another 83 patients did not meet the inclusion or exclusion criteria, and in the end, this meant that only 40 patients were randomized, 18 to niraparib, 22 to placebo. Looking first at the characteristics of the surveillance population, so 88% of patients had triple-negative breast cancer. If at the bottom left we look at the local BRCA status, 22% were mutant, 36% were wild type, and 40% were unknown. The vast majority, of course, those would have been wild type. And if we look at the stage, 25% of patients enrolled with stage 1, 40% with stage 2, and 30% with stage 3. And of the patients who had neoadjuvant chemotherapy, 34% had a path-CR. First of all, now looking at the associations with ctDNA detection on the trial, and these are the same associations, of course, that we have with recurrence risk. So if we look at stage first, stage 1 cancers had a 2% ctDNA detection rate, and this rose up to 13% in those patients with stage 3. Similarly, on the right, if we look at pathologic outcome to neoadjuvant chemotherapy, those patients who had a path-CR had a 2% ctDNA detection rate, and non-path-CR had a 13.7% ctDNA detection rate. We then look at the timing of ctDNA detection from the end of definitive treatment, and I remind you this is predominantly a triple-negative breast cancer study. So ctDNA detection rates were highest within the first 3 months after the end of definitive treatment, and then subsequently fell with time from end of treatment. And in triple-negative breast cancer, 60% of the ctDNA detections occurred within 6 months from the end of definitive treatment. We next tried to tease out the factors that associated with the diagnosis of a radiographic recurrence at the same time as ctDNA detection. So the table on the left looks at ctDNA detection and recurrence rates by visit. So if we look at the first test or visit, there was a 52.5% recurrence rate, and this fell on subsequent tests, but only very modestly to 43.8. And now on the right, we look at recurrence by ctDNA level or molecular burden. First of all, in the left part of that figure, at that screening visit 1, where patients have not had a test before, in pink is the ctDNA level in those patients who had concurrent recurrence, and you can see this is substantially higher than those patients who you're diagnosing an occult recurrence. And then on the right is ctDNA detection at later visits, so patients who had first had an undetected result and then converted to detection. And here you can see there's a group of patients who have very high levels of ctDNA, even though they did not have ctDNA detected approximately 3 months earlier. And this picks up the rapidity of the disease here and the difficulty of intercepting this with circulating tumor DNA, although conceivably a more sensitive assay might have been able to pick up these patients at an earlier time point. And then finally, I show you the characteristics of the randomized patients. Because of low numbers, we merged both cohorts. The one factor I just want to highlight here is in the patients who were treated with niraparib, only one had a BRCA mutation by central tumor BRCA testing. And if we look at recurrence-free interval, I remind you only 40 patients were randomized, and so we must treat this data with appropriate levels of caution. The median recurrence-free interval was 5.4 months in patients treated with placebo, and that increased to 11.4 months in patients treated with niraparib, with a hazard ratio of 0.66, but wide confidence intervals, well crossing 1. And I just need to highlight to you that investigators were unblinded at the time that study enrollment was terminated. And then finally, in an exploratory analysis, we looked at baseline ctDNA level, molecular burden, and the association of that with recurrence-free interval in the randomized patients. So split by their median ctDNA level, ctDNA high on the left, low on the right, And so in this exploratory analysis, you can see that recurrence-free interval may be longer with a hazard ratio of 0.46 in patients who had low levels of ctDNA prior to randomization. And so in conclusion, ZEST was the first phase 3 trial of MRD-guided therapy in breast cancer. The trial was terminated, though, because of low randomization rate, and this largely reflected broad entry criteria that allowed a relatively large number of low-risk patients to enroll that resulted in a low rate of ctDNA detection. There was a relatively high rate of metastatic disease at the time of ctDNA detection, and for patients with triple-negative breast cancer, ctDNA detection occurred most frequently on the first test and within 6 months of the end of treatment, consistent with the early recurrence that is, of course, typical of triple-negative breast cancer in this setting. There was a high rate of radiographic recurrence at the time of ctDNA detection, providing support potentially for strategies that start ctDNA testing earlier in the trajectory of triple-negative breast cancer. And I just highlight that the trial was not powered to evaluate the impact of niraparib versus placebo, although recurrence-free interval was numerically longer in these patients on niraparib. And as our authors, we would like to thank all of the participants and their families, and certainly the investigators and site staff who contributed to the clinical trial. Thank you.
Thank you. We have the time for a few questions. The mic number 5, please.
Andrew Tutt, London. Nick, thank you. Fantastic study. As we know, a high proportion of these patients have deficiencies in the homologous recombination beyond BRCA mutation. Can you tell us, is that characterized in the study and how that affects ctDNA performance and your results?
I'm sorry, could you just repeat that second part? I couldn't hear it.
It's a question around characterization of HR deficiency by mutational signature or beyond the germline BRCA mutation you describe. Is that characterized in the study? Because there's roughly 50-60% of patients who have that form of triple-negative breast cancer. And
yeah, so
how does that play into the results?
It was characterized in the study, and broadly there was no difference in the ctDNA detection rates in triple-negative who were HRD deficient as assessed by the Myriad assay versus those that were HRD proficient. Broadly, the ctDNA characteristics look the same in those two groups.
Thank you.
Mic number 4, please.
Nick Murray, Adelaide, Australia. Nick, that's really bad luck. And I wonder, is your next plan to look for ctDNA perhaps towards the end of completion of neoadjuvant chemotherapy to see if you can pick people out there?
Oh yes, we've certainly seen data that suggests that ctDNA detection at the end of neoadjuvant chemo before surgery is also associated with a very high risk of future relapse. And that will potentially, as we mentioned in one of the highlight conclusions, that will potentially allow us to get ahead of the pace of disease. Because we've shown that in some of these patients that we unfortunately see in the clinic, if they've not had a good response to their neoadjuvant chemotherapy, their risk of early relapse and the pace of disease is high, and therefore it is difficult to intercept with ctDNA monitoring.
We have a room for one last question. The mic number 6, please.
Michael Ignatiadis, Zolborda Institute, Brussels. Nick, great work, congratulations. To continue the discussion and the question before, what are your thoughts on the next steps for interception based on ctDNA in triple-negative breast cancer post-surgery?
Yeah, thank you for the question. So there was a tension in enrollment into this study. So the study was designed in a way that allowed low-risk patients to enroll. And of course, these patients have a high fear of recurrence, but their ctDNA detection rates are very low. And this is a real problem for a study that wants to randomize patients between treatment arms. And so I think one of the features that this emphasizes is in a clinical trial that ultimately is interested in how we treat people on ctDNA detection, We need to design our studies to enroll a relatively high-risk patient population, so we have a relatively high conversion of enrolled patients into the study. And I think that was one of the main challenges we saw here, and also to make sure as much as possible that the patients who enroll into ctDNA surveillance are then going to be eligible for the randomization.
I guess we'll stop it here. I believe you have lots of questions. Dr. Tana, thank you so much.
Thank you very much.
Lots of the questions will be answered by Dr. Krop, who from Yale School of Medicine in New Haven, who will be discussing this abstract.
That's a lot of pressure. So good morning. I'd like to thank the organizers for giving me the opportunity to discuss what I think is a very interesting abstract, and thank Dr. Turner and colleagues for providing their slides. These are my disclosures. So a key responsibility for medical oncologists is to create an optimal treatment plan for each of the patients we see with early breast cancer. We want to make sure we're not using too much therapy nor too little. And to be able to achieve this kind of Goldilocks level of personalization is particularly complicated now by the fact that we have even more potential treatment options available, each with their own risks and benefits that have to be considered. So optimizing treatment requires a number of variables to be known, but in particular, we need to accurately assess a patient's risk of recurrence. And we have a number of ways to do that in the clinic. We have anatomic features such as nodal involvement, molecular features, genomic features, and now we even use functional markers like how a patient's cancer responds to neoadjuvant therapy. And by using a combination of all of these features, we've been able to improve the personalization of our treatment and improve outcomes. We use less chemotherapy for hormone receptor positive and small HER2 positive cancers, and we're able to appropriately escalate therapy for patients who have residual disease after neoadjuvant therapy. But all of these markers have the same fundamental limitation. They're not telling us who actually will or will not recur. They just give us the probability of that event happening. Now, it's certainly important and helpful to know when a patient has only a 10% risk of recurrence, but for that individual patient, what's really important is whether they're one of the 90% of patients who don't have micrometastatic disease or one of the 10% who do. And we're not able to do that at this time, and that leads to uncertainty and understandable anxiety amongst our patients, and it leads us to overtreat and undertreat many patients. So if we are going to revolutionize how we select optimal adjuvant therapy, we need to go beyond these probabilistic markers. Fortunately, we now have the technology to detect circulating tumor DNA, or ctDNA. This is DNA that's released in real time by micrometastatic cells that are persistent in the body. And thus, it offers the potential to identify the specific patient with micrometastatic disease, not just those who are at risk. And in small retrospective studies, a positive ctDNA test is strongly associated with distant recurrence. There's multiple studies that all show that hazard ratio between the patients who do not have positive ctDNA and those who do is about 20, so a very strong prognostic effect. And the lead time, that is the time from when a patient's test is positive and they eventually develop recurrence, has been about a year in multiple studies. And now, as of report at ASCO this year, we have a much larger data set to look at. Data from the MONARCH-E study demonstrated that in those patients who have persistently positive ctDNA, as shown in the dark gray, they have almost 100% risk of eventual distant recurrence, whereas those who are persistently negative or undetected have only a low risk of recurrence, as shown in blue. Interestingly, the patients who originally were positive but then become negative during the trial had an intermediate risk of recurrence, suggesting that the therapy on the study led to the eradication of micrometastatic disease. So ctDNA testing can clearly identify patients with early breast cancer who have a very high risk of recurrence. Can we use it to guide our adjuvant and neoadjuvant therapy? Well, before we start doing that in the clinic, we need to demonstrate clinical utility. That is, does this testing improve outcomes for our patients in terms of survival, in terms of quality of life? But as yet, we do not yet have that kind of data in breast cancer. Fortunately, our colleagues in GI oncology have demonstrated through this very bold trial called the Dynamic study, which enrolled patients with stage 2 colorectal cancer and randomized their selection of adjuvant chemotherapy, either through standard management by clinical criteria or ctDNA guided management, where patients who were ctDNA positive were given adjuvant chemotherapy, and those who were ctDNA undetected were just observed. And this was a non-inferiority study, and it demonstrated that ctDNA guided selection of chemotherapy was non-inferior to standard management. And importantly, in the patients who had their chemotherapy selected by ctDNA guidance, they had half the rate of chemotherapy use as those patients who were selected for chemotherapy using clinical features. And interestingly, in longer follow-up, those patients who were originally ctDNA positive but then cleared their ctDNA during treatment had a relatively low risk of recurrence, as shown in blue, whereas those who had persistently positive ctDNA had a high risk of recurrence, again suggesting that the intervention, in this case adjuvant chemotherapy, led to the eradication of the micrometastatic disease. So, as I said, we do not have that type of definitive trial in breast cancer, but with the ZEST trial, the authors should be commended for doing the first large study where patients who had completed their standard adjuvant therapy were tested for ctDNA presence, and those who had a very demonstrated high risk of recurrence were then potentially randomized to a novel intervention. As you heard, though, this trial was found not to be feasible because of the very low rate of ctDNA positivity and the fact that 50% of the patients who were ctDNA positive had demonstrable metastatic disease at the time their test was positive. Now, the main reason, as Dr. Turner mentioned, for that low positivity rate was because in the surveillance population on this study, there was a large fraction of relatively low-risk patients. 2/3 had had stage 1 or 2 disease, and over 1/3 had had a pathologic complete response. And as expected, the majority of patients who were ctDNA positive were actually stage 3, and those who had residual disease after neoadjuvant therapy. But just to be clear, and this was brought up in the question, the last question to Dr. Turner, there's certainly nothing wrong with the idea of allowing a broad risk of clinical risk patients onto a ctDNA-guided trial. Of course, the whole idea is that ctDNA testing is more sensitive and more specific than clinical risk features. So eventually, we want to get to a situation where we're using ctDNA to enroll and select patients for this type of intervention instead of using clinical risk. But as was mentioned, that does entail screening a lot of patients. And when we're in this era where we're trying to show proof of concept of this approach, it probably makes sense to consider restricting to relatively high-risk patients only so that we can cut down the number of patients who need to be screened. So the other challenge that was noted in this trial was the fact that there was a high prevalence of metastatic disease at the time of a ctDNA detection, and Dr. Turner's team recommends using this type of testing earlier in a patient's course, and that makes perfect sense. But as you heard, 60% of the patients on this trial actually were tested within 6 months of their end of treatment, and in a large fraction were tested within 3 months, and even these 3-month patients still had a very high rate of metastatic disease at the time of their positive test. So it's a little worrisome that it may not be possible to get substantially more, fewer patients with metastatic disease, even if we move earlier in the course of triple-negative disease. And I think, again, as was mentioned, that probably just reflects the rapidity at which triple-negative disease moves. And I just wanted to highlight one more aspect of this trial, which is the lead time. Again, that is the time from when a patient has a positive test and when they develop metastatic disease. This wasn't reported in this trial, but if you look at the time at which patients who were ctDNA positive and then randomized to placebo, the time at which they recurred was a very short 5 months. And that even does not include the fact that half of those patients already had metastatic disease at the time that they were tested, which suggests that the real lead time from this study is very short, again, probably reflecting the pace of triple-negative disease. So where are we now? What do we need to do to truly revolutionize how we tailor therapy for early breast cancer? How do we land this plane, so to speak? So for using ctDNA to identify high-risk patients to evaluate a novel therapy, as was attempted in ZEST, I think we already have the tools to do this. As we talked about, selecting for higher-risk patients and testing as early as possible from completion of adjuvant standard therapy should improve the feasibility of this, and as well as improving the sensitivity of ctDNA testing. But I just want to be clear that we do need to formally test this approach before we start using it in the clinic. It is possible that outcomes such as survival cannot be meaningfully changed in patients who are already significantly ctDNA positive. I don't think that's the case based on the data we have, but it does need to be formally tested. And so why do we even need to establish clinical utility for a test like this before we start using it widely? And that's because this test, like any intervention, does have potential harms. We can imagine increased toxicity from starting a therapy earlier than needed, or the therapy is ineffective in this situation. Patients with positive ctDNA could potentially discontinue a therapy that's actually effective. It just hasn't had time to clear their ctDNA at that particular moment. And of course, this kind of testing is associated with significant anxiety for our patients, particularly if they receive a positive test result. And then conversely, those patients who have a negative result could be falsely reassured that they're not at risk for eventual recurrence where they might be. There are a number of trials underway asking these clinical utility questions, and I think we will have results relatively quickly to address this important issue. So now using ctDNA to try to de-escalate therapy, a different question. I don't think it's quite clear that we're ready to do this as of now with the current technology. We're still seeing substantial relapses in patients who are ctDNA negative, particularly at baseline. So I think we'll be better off when our tests become more sensitive, and by using serial testing as opposed to just baseline testing, that also will improve this type of approach. But ctDNA testing is improving, and the technology actually is improving quite rapidly. The state of the art right now is to use whole exome sequencing to identify a modest number of probes. 16 were identified for the testing that was done in the ZEST trial. But there are now approaches using whole genome sequencing to identify a very large number of tumor-informed probes, which theoretically should improve sensitivity. And in fact, in a cohort of 78 patients with early breast cancer who were reported at ASCO this year, they showed a very high sensitivity, a lead time for recurrence of about 15 months, and a very impressive 100% positive and negative predictive value. Other technologies in development are also quite promising. So in conclusion, in early breast cancer, multiple studies show a very strong association between the detectable ctDNA and distant recurrence, and offer the potential for finally moving away from probabilistic testing and be able to identify the actual person who will develop recurrence without intervention. But as of now, no study has shown prospectively that intervening on a positive test improves outcomes, and no study has shown that de-escalating therapy based on a negative test is safe. So given this lack of evidence that ctDNA-guided therapy in early breast cancer improves outcomes, using these type of tests to guide therapy should only be done as part of a trial, and I can't really stress that enough. But there are prospective studies ongoing, and their technology continues to improve quite rapidly. So I'm quite optimistic that ctDNA testing will be validated as a revolutionary tool to be able to improve outcomes for our patients. I'd just like to acknowledge help from Dr. Heather Parsons and Dave Siskin for their slides and consultation. And if you're interested in this topic and want to learn more, I would strongly recommend that you go online and review the educational session 2 that happened on Tuesday, addressing a lot of these questions in very substantial detail. So thank you.
Thank you, Dr. Krop. Our next abstract is impact of anthracycline in high genomic risk node-negative, hormone receptor positive, HER2 negative breast cancer by Dr. Chen from University of Chicago.
Good morning. It is my pleasure today and a privilege on behalf of my co-authors to present our work today. Thank you to the organizers of the meeting for this honor. These are my disclosures. The TAILOR-X study demonstrated the benefit of chemotherapy in HR-positive, node-negative breast cancers with a recurrent score of 26 or greater. This post-hoc analysis of the TAILOR-X demonstrates benefit from the addition of anthracyclines to a taxane-based regimen in cancers with a recurrent score of 31 or greater. Furthermore, we noted that this benefit is primarily limited to tumors greater than 2 centimeters in size, and this benefit increases with increasing recurrent scores above 31. The role of chemotherapy in the adjuvant treatment of high-risk, early-stage HR-positive breast cancer has evolved. The ABC trials evaluated the potential non-inferiority of taxane plus cyclophosphamide for 6 cycles versus taxane plus anthracycline-based therapy with the primary endpoint of invasive disease-free survival in early-stage HER2-negative breast cancer. There was no benefit in anthracyclines in the overall subset of HR-positive cancers, and furthermore, there was a poor correlation between the number of lymph nodes and the benefit of anthracycline, suggesting that nodal status may be a poor biomarker for anthracycline benefit in this patient population. In previous studies, recurrent scores of 26 and 31 have been utilized to evaluate for the benefit of chemotherapy. In this analysis, we chose the RS cutoff of 31 to best isolate the patients at the highest genomic risk. The TAILOR-X study enrolled patients with stage 1 and stage 2 node-negative HR-positive breast cancer. Patients with a low recurrent score received endocrine monotherapy. Patients with an intermediate recurrent score received endocrine therapy with or without physician's choice of chemotherapy. And patients with a high recurrent score received endocrine therapy and physician's choice of chemotherapy. In our analysis, we included patients with a recurrent score of greater than 11. We excluded patients who did not receive chemotherapy or received an alternative chemotherapy that was not TC or TAC. Lastly, we excluded patients with missing covariates such as age, tumor size, or hormone receptor status. Ultimately, 2,549 cases were included in our analysis. Here we see patient characteristics, which are reflective of physician prescribing patterns. We see that in patients receiving TAC, they were more likely to be younger, with a mean age of 53. They were more likely to be premenopausal. They had larger tumor size with a mean size of 19.6 millimeters. Patients receiving TAC were more likely to have high-grade disease, and they were more likely to be progesterone receptor negative. Patients receiving TAC had higher recurrent scores than patients receiving TC, with a mean recurrent score of 29.6. The majority of patients in our analysis received TC, including at the highest recurrent scores of 31 or greater. However, increasing proportions of patients received TAC at increasing recurrent score categories. Within the TAC subgroup, the majority of patients received taxane with either dose-dense or standard anthracyclines. A minority of patients received concurrent TAC, and some patients received another standard anthracycline and taxane-containing regimen. All patients in the TC group received taxane with cyclophosphamide. To most directly assess the impact of anthracyclines on breast cancer recurrence, we analyzed distant recurrence-free interval at 5 years. To compare the treatment groups, we evaluated adjusted hazard ratios controlling for age, hormone receptor status, recurrent score, tumor size, treatment received, and interaction of treatment with recurrence score. As you can see on the left, in patients with a recurrence score of less than 31, there was no significant benefit with the addition of anthracyclines. However, on the right, we can see that in patients with a recurrence score of 31 or greater, there was a significant absolute benefit of 5.1% of 5-year distant recurrence-free interval with the addition of anthracyclines, resulting in an adjusted hazard ratio of 0.32%. Distant recurrence-free survival was similarly significant with an absolute benefit of 5.6% and an adjusted hazard ratio of 0.47. Overall survival demonstrated a numerical trend towards improvement with an absolute benefit of 3.8%. However, this was not statistically significant. In unadjusted subgroup analysis categorized by age, menopausal status, tumor size, tumor grade, and progesterone receptor status, we see that in all subgroups in patients with a recurrent score of greater than 31, the addition of anthracyclines improved 5-year distant recurrence-free interval. However, in our secondary analyses, we see that this benefit was primarily limited to tumors that were greater than 2 centimeters in size. Menopausal status in our analysis was defined as per the TAILOR-X study. We see benefit in both premenopausal as well as postmenopausal patients with similar adjusted hazard ratios, suggesting this benefit may be less likely related to the ovarian suppressive effects of additional anthracycline chemotherapy. Nonetheless, there was a greater magnitude of benefit in the premenopausal patients with an absolute benefit of 12.5%. This may be related to other factors such as increased clinical and genomic risk in this subgroup of patients. We wanted to further explore the relationship between anthracycline benefit and recurrence score. We see on the x-axis recurrence scores increasing from 1 to 50, and we see on the y-axis increasing hazard ratios comparing TC to TAC, with decreasing hazard ratios representing increased benefit. We can see at low and intermediate recurrence scores, the curves are very similar and thus suggesting there's very little benefit, if any, to adding anthracyclines to these patients' regimens. However, with increasing recurrence scores, we see that benefit is starting to improve. And ultimately, at a recurrence score of 50, we note an adjusted hazard ratio of 0.45 in patients with this high-risk disease, suggesting that increasing recurrence scores have an increasing benefit of anthracycline. While many patients in the TAILOR-X study did receive either TC or TAC, some patients received alternative chemotherapy regimens, such as anthracycline without taxane or CMF. Some patients also did not receive chemotherapy at all. We see that these alternative chemotherapy regimens perform less poor or more poorly than TC and TAC, especially at higher recurrence scores. There are some limitations of this analysis. This was a post-hoc analysis, and the primary study was not designed to evaluate anthracycline benefit. Furthermore, the choice of chemotherapy was not randomized and was reflective of physician prescribing patterns and potential physician biases. And lastly, there are late effects of anthracycline usage, such as the increased risk of secondary hematologic malignancies that may not be accounted for in the follow-up period of our analysis. Nonetheless, despite the bias of higher-risk patients receiving anthracyclines, this analysis still noted a benefit in high genomic risk patients. In conclusion, in patients with HR-positive, node-negative breast cancer with a recurrent score of 31 or greater, we demonstrated a significant benefit in 5-year estimates of distant recurrence-free interval and distant recurrence-free survival in patients receiving TAC compared to TC. We also noted a trend towards benefit in overall survival. This benefit was most clearly demonstrated in patients with tumors greater than 2 centimeters, and we also noted increasing recurrence scores greater than 31 corresponded to an increased benefit of addition of anthracyclines. Anthracyclines should be considered in patients with high genomic risk, HR-positive, node-negative disease. I'd like to thank Dr. Joseph Sperano and Dr. Bob Gray for their assistance in this work, as well as the NCTN and Krop Data Archive. Lastly, but most importantly, I'd like to thank the participants and their support system. Thank you very much for your time and attention.
Thank you so much. We have a room for a few questions. While mic number 2, please.
Hi there, Matthew Getz from Mayo Clinic. Just want to congratulate you on this. And just as a comment, you know, the EBCTCG has published data, including in Lancet 2023, again demonstrating that the TC regimen is a non-inferior regimen compared to anthracycline-based regimens. And of course, it's based on, you know, or independent of a variety of factors. But I think your data are actually supporting that proper selection of patients really is critical. But I want to comment on the question of really, you know, if the anthracyclines are superior anthracycline regimens to TC in this high-risk regimen, and TC has been given in low risk, when should we use TC?
Yeah, I think that's an excellent point. I absolutely agree that patient stratification is really important, and I think that one of the things we wanted to highlight was the use of recurrence score as opposed to some clinical pathologic factors that we typically use. I certainly think that, so we also performed an analysis on patients with a recurrence score of 26 to 30 and demonstrated that those patients did not benefit from the addition of anthracyclines. So certainly that's a patient population where I think TC would be very reasonable. We also noted that this benefit was primarily in tumors that were greater than 2 centimeters in size. And so small tumors may still be very reasonable to be treated with TC. And lastly, you know, we recognize that anthracyclines carry additional toxicity, not just the secondary hematologic malignancies that I mentioned, but also cardiotoxicity. It can result in longer treatment durations. And so we must keep all of this in mind when deciding treatment regimens appropriate for our patients.
Mic number 6, Dr. Vogt.
Vogel, New York. Very nice paper. You know, the recurrence score is a construction that was made very carefully to pick out women who did very well with adjuvant tamoxifen. It wasn't designed for chemotherapy sensitivity. Now, to get to a high recurrence score, usually you have to be HER2 positive, or at least HER2 expression positive, or you have to have a lot of proliferation. Presumably, these were all HER2 negative patients, and HER2 was pretty low. Were you basically looking at proliferation in these tumors? That's available from the Genomic Health Report.
So absolutely.
The question for the resource-deprived part of the community we're talking to is, can you just do a Ki-67 and not send the specimen to California?
Absolutely, I agree. I fully recognize that 21 gene recurrence scores may not be available to everyone internationally, and that there may be other ways that we can identify these patients. One of my colleagues is working on digital pathology to see that if there's a way, even using H&E slides, to identify these patients as well. I think to your point about, you know, HER2 positive patients or even triple negative patients having higher recurrence scores, I think the 21 gene recurrence score includes endocrine sensitivity as well as estrogen receptor expression. Certainly patients who are more akin to maybe triple negative biology will have higher recurrence scores, and certainly the benefit of anthracyclines is much more established in triple negative patients.
I was just wanted you to go look at the reports and see if it was all proliferation that was driving these high scores.
Yeah, I think
Have you done that?
That's a really great point and very well taken. Thank you.
Mic number 5.
Hal Burstein from Boston. Terrific presentation, exciting to see these data. I would say they look very much aligned with what Joyce O'Shaughnessy presented on the MammaPrint High-2. It's a very supportive idea. Could you just say a little more about the T1 outcomes in quantitative terms? Obviously, you pointed out the hazard ratio is not statistically significant, but how much, if any, benefit would there have been? I just want to make sure we're not suddenly dumping a lot of anthracyclines in 1 centimeter cancers that have an oncotype score of 31 if we don't need to.
Yeah, absolutely. I think so. That relationship was only significant for our primary endpoint of distant recurrence-free interval. For other endpoints such as distant recurrence-free survival, recurrence-free survival, it was not significant. And thus, I agree with you that I would caution providers in interpreting this data that I agree not all stage 1 tumors would benefit from anthracyclines, and that this benefit was primarily in tumors that were 2 centimeters or greater in size.
We have a room for one last question, quick question and a quick answer. Mic number 2.
Hi, Fraser Simmons from MD Anderson. It's interesting, a comment for your response. It's interesting to note that of the chemotherapy regimens used in these randomized trials for physician's choice, they're predominantly taxanes, right? And but some usage of anthracyclines, which is you're talking about. But going into these studies, the evidence from the retrospective randomized trials was very strong for prediction of anthracycline benefit, SWOG 8814. And this seems to confirm that. And the prediction in the taxanes was not as strong in the previous studies, although they were never compared to no chemo. And that also seems to be confirmed by the TAILOR-RX and RxPonder experience. Care to comment on that?
I'm sorry, could you clarify your question? I was having a little bit of a difficulty hearing it clearly.
Sorry, that the prior evidence from studies was that there was strong prediction of anthracycline benefit,
Sure.
but not so strong for taxanes, addition to anthracyclines. And your data shows that the predictive component is about whether or not we use anthracyclines.
Yes.
Just for your comment.
Oh, I see. I think that, in modern era, typically taxane-based regimens are our standard, and our consideration is whether to add anthracyclines. I don't think this study was designed to necessarily evaluate taxanes and anthracycline therapies separately as individual components.
Okay, we are a bit over time. Thank you so much. Thank you, Chen. Next is adjuvant or neoadjuvant nab-paclitaxel weekly versus the solvently based paclitaxel Q2 weeks, followed by EC Q2 weeks, and genomically or clinically high risk hormone receptor positive, HER2 negative early breast cancer according to ET response. Final survival results from the West Germany study group ADAPT chemotherapy trial. Dr. Sherko Kuemmel from German Medical Institute in Berlin, please.
Dear ladies and gentlemen, dear colleagues, dear chairs, it's an honor and a pleasure to be able to present a final analysis of the chemotherapy cohort of the ADAPT trial. We investigated the neo or adjuvant nab-paclitaxel weekly schedule versus solvent-based paclitaxel every 2 weeks as a dose-dense fashion, followed by anthracycline cyclophosphamide every 2 weeks in genomically or clinically high-risk patients for HR-positive, HER2-negative disease according to endocrine therapy response. These are my disclosures. To bring you in the picture, I think we have to look at the ADAPT trial just more closer, to look where we are in the low and intermediate risk group for our patients every day. In the ADAPT trial, we registered more than 5,600 patients. All these patients are candidates for neoadjuvant chemotherapy by conventional prognostic criteria like larger tumor size, higher grading, or higher Ki-67 more than 15, or positive lymph node status. All these patients, or most of these patients, has an induction endocrine therapy of standard of care. Premenopausal patients, mostly tamoxifen or tamoxifen ovarian suppression, postmenopausal patients, mainly with aromatase inhibitors. During this time frame, we investigated the recurrence score using Oncotype DX test. Afterwards, most of the patients going to surgery or re-biopsy. Why we did this? We want to evaluate the Ki-67 downregulations and to spare the patients into responders or non-responders. If you look at this one, lymph node negative up to 3 positive lymph node patients with a recurrence score less than 12 go directly registered in the endocrine therapy alone arm. Additionally, patients with a recurrence score between 12 and 25, but with an endocrine therapy response, go directly to endocrine therapy alone. Over 2,000 patients, actually from 5,000 patients, were candidates for chemotherapy. In the chemotherapy cohort, patients could come with higher lymph node burden with N2 and 3, higher recurrence score with more than 25, or patients without endocrine response and the Ki-67 more than 10. They are directly come to chemotherapy cohort and randomized 2 different anthracyclines and taxane dose-dense regimen. In the control arm and standard arm, we investigated paclitaxel for 4 cycles, 175 milligram per meter square, followed by anthracycline cyclophosphamide bi-weekly for 4 cycles. And we compared this in the experimental arm with 8 cycles of nab-paclitaxel at the dosage weekly from 125 milligram per meter square, followed again by EC bi-weekly. What we learned from the ADAPT data program. First of all, we learned patient selection using both recurrence score in combination with endocrine response to determine dynamic Ki-67 is feasible in clinical practice. We learned and we saw that ADAPT-HR positive HER2 negative low to intermediate risk patients with endocrine response treated by endocrine therapy alone. Patients who had lymph node negative up to 3 positive lymph nodes and a recurrence score less than 25 have an excellent outcome without any chemotherapy, and this is the only trial irrespective of age with a 5-year distant disease-free survival of more than 96%. The endocrine response, the dynamic Ki-67, is an independent prognostic factor for distant disease-free survival. In the neoadjuvant chemotherapy cohort, we observed that patients with higher PCR rates with nab-paclitaxel versus paclitaxel, we saw higher PCR rates with higher recurrence score, but if biology matters, we see that recurrence score is more than 25, and patients with an endocrine response have a low PCR rate of only 5.6%. The rationale for the chemotherapy regimens. The impact of nab-paclitaxel on outcome data in early breast cancer subtypes remains to be defined after the ETNA trial data and the Gepa-Septo data. Those dense chemotherapy showed highest efficacy in early breast cancer disease patients. In HR-positive, HER2-negative early breast cancer disease, the optimal chemotherapy regimen and impact of PCR on survival are still unclear. Here we present the 5 years outcome and toxicity data for 2 sequential anthracycline taxane-based dose-dense regimen in HR-positive, HER2-negative patients pre-selected by recurrence score and endocrine response. The statistical methods. Initially, the primary objective was to show non-inferiority of nab-paclitaxel regarding 5-year DFS, including DCAS. After an amendment of 21, the primary objective was changed to demonstrate superiority of nab-paclitaxel over paclitaxel in invasive disease-free survival after 317 events or 5 years of follow-up. The actual number at the data cutoff of events was 308. IDFS defined according to the classical criteria. The Kaplan-Meier curves are compared with log-rank testing stratified for nodal status and study site. 5-year IDFS rates together with 95% confidence intervals are reported by treatment arms. Hazard ratios from Cox regression models are reported. The models include the treatment arm and nodal status. Secondary objectives are IDFS, relapse-free survival, distant-free survival, local relapse-free survival, overall survival, and event-free survival. And the analysis is performed in the intention to treat population. Let's look at the baseline characteristic. Because of the high number of randomized patients in the 2 treatment arms, we see a high degree of balance according to all criteria: age, nodal status, tumor stage, higher grading, recurrence score, Ki-67 at baseline, or Ki-67 post-endocrine therapy. Let's come to the primary endpoints. First of all, we saw in the DFS a significant better survival for patients using nab-paclitaxel with a hazard ratio of 0.82. Interestingly, after the amendment and the main endpoint now, the IDFS, we saw a trend of better survival using nab-paclitaxel with a hazard ratio of 0.84 for these patients. If you look at the key secondary endpoint, again, for relapse-free survival, we saw a significant benefit using nab-paclitaxel with a hazard ratio of 0.82. But for the main endpoints and key secondary endpoints, distant disease-free survival and overall survival, they were not statistically significant with hazard ratio of 0.86 or hazard ratio of 0.93. Let's look more closer if you have 2,000 patients, if you have endocrine response and recurrence score. If you bring this together and looking for different scheduling of chemotherapy, what we saw is patients with a recurrence score less than 25 without endocrine response are in favor and treatment of nab-paclitaxel. And bring this picture together with the two not randomized cohorts of the ADAPT trial with 5,600 patients. On the left side, you see the endocrine cohort with lymph node negative or lymph node positive disease patient up to 3 positive lymph nodes. The IDFS in patients with an recurrence score less than 25 or equally 25, and endocrine response without any chemotherapy and only endocrine therapy alone. We see independent and irrespective of age and IDFS rates of 93.2 or 92.8%. If you look at the other group, at the chemotherapy cohort with a recurrence score less than 25 without endocrine therapy response, we see with nab-paclitaxel an IDFS rate of 91.5% versus 87.2%. We saw no new data for the safety signals. The hematological and non-hematological toxicity, we saw with all patients 7.9% of paclitaxel and 7.8% with nab-paclitaxel discontinued due to an adverse event. We saw with nab-paclitaxel more grade 3 events, more hematological toxicity, and interestingly less neuropathy. 2 non-treatment related deaths we observed in both study arms. In conclusion, the ADAPT trial established that the combination of clinical risk, genomic risk, and endocrine response Ki67 downregulation allows optimal patient selection for endocrine therapy or chemotherapy in HR-positive, HER2-negative early breast cancer disease. Endocrine therapy alone in lymph node negative or up to 3 positive lymph nodes, irrespective of age, the only trial in the world for that, with a 5-year distant disease-free survival of more than 96%. At the ADAPT chemotherapy cohort, we saw that nab-paclitaxel versus solvent-based paclitaxel in a dose-dense sequential anthracycline taxane chemotherapy regimen in HR-positive and HER2-negative early breast cancer disease resulted in similar 5-year IDFS distant disease-free survival and overall survival rates. Both taxane-based regimens have manageable safety profiles and low discontinuation rates and can be considered as standard chemotherapy options in high-risk HR-positive early breast cancer disease patients. And I conclude, to hold up the picture, the fully recruited ADAPT-CYCLE trial will demonstrate whether chemotherapy can be replaced by a CDK4/6 inhibitor-based regimen in intermediate to high-risk cancer patients with HR-positive to negative disease. And this is the design of the trial, and we expected the data 2027 with the randomization in the intermediate risk group of 600 milligram of ribociclib for 2 years versus conventional chemotherapy. I would like to thank you, Nadja Habeck, Ulrike Glitz, Oleg Luz, and Peter Schmidt for the ADAPT trial, this exceptional trial in that situation. All patients who agreed to participate in the ADAPT trial and to donate their tissue for research. ADAPT study centers, investigators, and site personnel, our financial sponsors, the Data Safety Monitoring Board, and our colleagues from the Central Pathology in Hanover, and all WSG operational team members. And you can scan the QR code and then you can download the presentation. Many thanks for your attention.
Thank you, Dr. Kuemmel. Questions? The mic number 4, please.
Nick Murray, Adelaide, Australia. It was quite hard to see on the slide, but what proportion of people had neuropathy, and in what fraction of those was that neuropathy persistent long-term?
So we don't have the long-term data. For the more grade 3 neuropathy, we have 6.3 versus 4.2% versus the 2 taxanes.
Grade 3's in a wheelchair.
I know. But
so that's a lot. What about grade 2? Grade 2 means your life has changed.
I know, but as always, you know, if you have these thousands of patients and the experiences, all the trials, but whatever you see, that I think the documentations of the neuropathy is not that easy, and you only can see what the data are. Yeah, the percentage of the patients is something around 20%, but most of the patients, what we saw, and that we saw in the Percepto trial and other trials too, that most of the patients, they have lower rates after 90 days.
I think we need to get better at picking up neuropathy early and stopping treatment.
Mic number 5, please.
Hope Rugo, UCSF. Great presentation. Thank you. In response to the other question, I think the problem with our reporting of toxicity is we report a single episode. We don't say anything about duration. and what impact there is on quality of life, even with our current reporting. But in that vein, neuropathy, I think, is, other than having secondary cancers, is one of the biggest long-term toxicities from early-stage curable therapy. So wouldn't this be an argument to switch to nab-paclitaxel in patients who have early evidence of neuropathy? And also, of course, it's important to be thinking about the cryotherapy and compression studies that are going on to try and prevent this. The question really is about changing to nab-paclitaxel.
So, of course, thanks for this excellent question. So, what we estimated here and what we have is 2 short dose-dense, highly effective regimen. This is the first situation, with 4 cycles paclitaxel every 2 weeks with 175 milligram, or only 8 cycles of nab-paclitaxel. So if you compare this, I think cross-trial comparison is always difficult to see at that situations. I think we have a low number of P&P for these patients actually in comparison for that. I wouldn't assume to say if I have starting with a neuropathy, I would switch to nab-paclitaxel. I think this data are not sure to do that.
In my anecdotal experience, it's quite effective.
Yeah.
Mic number 2.
Yes, Saikov from Brown University. I want to thank you again for an excellent presentation. I think interpretation of the data is a little bit challenging when you're comparing different doses, formulations, and schedules of the taxane. And for a relatively modest benefit, I also think it's a lot easier to monitor patients closely and dose reduce in patients who develop what I like to call grade 1.5 peripheral neuropathy and not wait for them to get to grade 2 or grade 3. I'm just curious about your thoughts about the multiple differences between the taxane regimens between the 2 arms.
So first of all, if you see, always we have to look back. If it's 10 years ago that we designed the ADAPT trial and make the first thoughts on that, at that time, the maybe most accepted dose-dense regimen was this, what called citron data with 4 cycles of paclitaxel and afterwards 4 cycles of anthracycline-based therapy biweekly. So if what we mentioned and what we know is that maybe number of cycles in HR-positive disease plays a role. So that's why we created this trial to have the same maybe long journey for the patients of therapy. This was the most important point for us to make it comparable. Otherwise, you have 12 weeks, cumulative dosage, etc. So we focused on time and said 8 weeks versus 8 weeks, and 8 weeks with anthracyclines again versus 8 weeks to make it comparable. This was the idea behind that one. Because of the data, if you see more cycles, etc., and the efficacy in HR-positive disease, this is the reason for that.
Thank you.
Okay, thank you so much, Dr. Kuemmel. Our next abstract is NSABP B-59, the German breast group, a randomized double-blind phase 3 clinical trial of neoadjuvant chemotherapy with atezo or placebo, followed by adjuvant atezo or placebo in patients with stage 2 and 3 triple-negative breast cancer by Dr. Charles Geyer from University of Pittsburgh. Please.
Thank you. Good morning. On behalf of my colleagues in the NSABP Foundation, the German Breast Group, and IDDI, and our collaborating investigators from GEICAM, TRIO, and US Oncology, it is my distinct privilege on their behalf to present to you today the definitive results of NSABP B-59, GBG Gepard-Deuce. This was our academic collaborative effort, was a double-blind phase 3 clinical trial of neoadjuvant chemotherapy with atezolizumab or placebo, followed by adjuvant atezolizumab or placebo in stage 2 and 3 triple-negative breast cancers. These are my disclosures. I think everyone in this audience is familiar with the rationale for evaluating a checkpoint inhibitor in early breast cancer. Triple-negative breast cancer is an aggressive subtype with high tumor mutational burden and potential susceptibility to immune checkpoint inhibitors. Atezolizumab is an anti-PD-L1 antibody that has previously been shown to improve the PCR rate of early-stage TNBC when added to neoadjuvant chemotherapy. and also demonstrated improvement in PFS when added to chemotherapy in metastatic breast cancer. Those studies demonstrated that the atezolizumab could be combined with standard chemotherapy with manageable toxicities. So our study was designed to determine if the addition of atezolizumab to standard neoadjuvant chemotherapy regimens would improve outcomes. This is a summary of our study design. In terms of eligibility criteria, they were relatively straightforward. We did require central testing for ER, PR, and HER2. We initially did not include PD-L1 testing as an stratification factor. This was later added to the study, so patients also had central testing PD-L1 throughout. Patients were eligible for the trial if they had T1 tumors, as well as a clinically positive node that could be clinical N1 to clinical N3, T2 or T3 tumors irrespective of nodal status. T4 patients were excluded on our trial. The other major exclusion criteria were, of course, those that are related to use of a checkpoint inhibitor. Our stratification factors on the study were the two groups, NSABP versus GBG as separate groups. We decided to split the size of the primary tumor into roughly equivalent cohorts, we thought, of 1.1 to 3 centimeters and greater than 3 centimeters rather than the T2, T3. Clinical nodal status was another stratification, positive or negative. Positive meant that the imager basically said this is clearly abnormal and a biopsy wasn't done. If a biopsy was performed, it needed to be positive. PD-L1 status was assessed by the Ventana SP142 assay, and just to remind everyone, positive is 1% or more of immune cells in the tumor area staining positively. We could have negative results, indeterminate results, and then as you'll see, we also had a not available category for those early patients where we were not doing it early enough and including it to include it as a stratification variable. Finally, we allowed choice of dose dense or not, so we added that as yet another stratification variable. So a number of stratification factors in the study. The chemotherapy backbone we chose came basically from the brightness study, weekly paclitaxel for 12 weeks with carboplatin AUC of 5, followed by AC or EC, depending on which of the two groups were entering the patient. All patients received that therapy, and randomization then, of course, was concurrent atezolizumab versus placebo throughout neoadjuvant chemotherapy, and then continued in the adjuvant setting according to the initial randomization. One thing I do want to point out about the adjuvant setting is our trial accrued over a 41-month period of time, during which time Createx reported out, and the use of capecitabine was increasingly accepted as a standard of care, and so we did gradually allow and amend the protocol for patients to receive capecitabine who had a non-PCR. The official amendment went into effect in February of 2020. Right at the tail end, we also had to allow olaparib, but that was just a handful of patients. These are our study endpoints. Event-free survival was our primary endpoint. Today, we're just able to give top-level results. I'm going to focus on overall survival, PCR, and toxicity. We will be looking at these other secondary efficacy endpoints and exploratory endpoints. Statistical considerations, we set the study up to detect a hazard ratio of 0.7 for event-free survival between the two groups. We projected we would need 252 events to see that difference with an 80% power and an overall two-sided alpha of 0.05. We planned one interim analysis, which was performed last summer at 196 events. Obviously, since this is the first time you're hearing the data, we did not cross that boundary. Over the past year, our monthly event rate clearly had reached a low point, so we modified the statistical analysis plan to allow us to proceed with a definitive analysis when we had at least 242 events confirmed. At our database lock the end of October, basically 6 weeks ago, we had 243 EFS events that were confirmed. Given those numbers, controlling the overall type 1 error at 0.05, our two-sided superiority boundary for this analysis is shown. If we cross the primary EFS analysis, then we would formally analyze overall survival. These are our analysis populations. We had 1,550 persons randomized into the study. Efficacy was evaluated by ITT 777 in the placebo group, 773 in the atezolizumab group. The safety cohorts are shown at the bottom. We had 7 patients in the placebo arm, 11 patients in the atezo arm who never began study treatment, so they were not included in the safety population. In the placebo arm, we had 7 instances of patients receiving active atezolizumab instead of the assigned placebo, so they've been pulled over into the atezolizumab arm for safety. We also had 1 atezolizumab patient who did not take any, so they're in the placebo. That's how we derived to our safety populations. This is the patient population we accrued to the study. Median age was 49. This was a study that we, as you heard, did collaboratively with GBG and GICAM, so we had a high percentage of white patients, 90%. We did allow men, but we only had 1 male enter who was on the control arm. These are our stratification factors, our characteristics. We were balanced in all these, of course, with such a large study, but you can see 63% of our accrual was by the GBG groups. 59% of our patients were clinically node negative. 59% of the patients had smaller tumors, 3 centimeters or less. 36% of our patients were PD-L1 positive using the SP142 assay, and 64% of our doctors elected to use dose-dense AC. In looking at our tumor type, not surprisingly, triple-negative study, the large majority of these were invasive carcinoma of no special type and high grade. We prospectively assessed TIL centrally, and I had predefined that 30% or more would be a cut point that we would use for analysis, and 38% of our patients had the TIL above 30%. We collected but did not require germline testing. You can see a little over 1/3 of our patients did not have germline testing done, but in the patients tested, we had about 10% that had a germline mutation. In terms of drug delivery, these violin plots showed that we had good drug delivery of our chemotherapy overall. You can see there are no evident differences in terms of the 2 arms in terms of chemotherapy delivered. We looked at the complete delivery of chemo definition that was used in Keynote 522, basically at least 10 doses of weekly paclitaxel and all the carboplatin, all the ACEC, and using those definitions, 81% of our placebo arm patients had complete delivery, 78% atezolizumab. So slightly less, but really I don't think there's clearly evidence that any differences are related to chemotherapy delivery. So here's our results. With a median follow-up of 46.9 months. In our control arm, we had 133 events, fewer events in the atezo arm at 110. 4-year event-free survival was 81.9% in the control arm, 85.2% in the atezolizumab arm. Our hazard ratio was 0.8, log rank 0.08. We did not meet our pre-specified criteria to claim activity for atezolizumab in this patient population. If you look at the breakout of first type of EFS events, as is seen typically with these studies, distant recurrence was the predominant event type. We did track the locations of the sites of metastatic disease, and so we did keep these categories, planning to show in this analysis distant recurrence, which involved the CNS. That could be only the CNS. We have the information in the database, but don't have it for you today. But you can see that when you looked at distant recurrences where the CNS was involved, there's certainly no difference numerically, a little bit higher in the atezolizumab arm. When you drop down to distant recurrence, which didn't, and the CNS was not involved, there was this interesting drop from 53 down to 29 patients, about half as many recurrences outside the CNS. So it's an interesting suggestion there that atezolizumab wasn't helping with the CNS disease. Our subgroup analysis by our stratification factors was also interesting. We had, as you can see, heterogeneity amongst the groups. We did testing for significance for interaction, and one of our cohorts highlighted in red did show statistical significant interaction, specifically our clinical nodal status. I'll see if I can. You can see when you look at the clinically node negative, the hazard ratio group, the hazard ratio is basically 1. When node positive is 0.6, so there was an interesting split there by clinical nodal status. We saw a similar trend. Larger tumors seem to have a suggestion of benefit of atezolizumab that just wasn't there with the smaller tumors. And dropping on down to the TIL category, you see that those who had lesser TILs didn't seem to have the apparent potential benefit that might have been there. So while we overall can't claim at all that atezolizumab met criteria, I think we do have some interesting findings that will support some translational work moving forward. Moving to our secondary endpoints, PCR in the control arm was 57%. This is virtually identical to what was reported in the brightness study, so that our control arm group performed as expected. PCR rate was increased to 63%. To the right, we show the obligatory outcomes of EFS by PCR status, and we again see how strikingly important PCR is for prognosis. Obvious differences between our study and 522 is that we really do not see differences between the two arms in the non-PCR patients. The PCR group is kind of reminiscent of what was seen in 522. You can see that the 4-year event-free survival was 91% in the placebo group, 93% in the atezo group, virtually the same, about 70% for the non-PCR group. Overall survival, not surprisingly, no difference. Both arms are have about a 4-year overall survival of 90%, hazard rate 0.86. Leading cause of death is due to recurrence of the breast cancer, as one would expect. Moving to safety overview, really no surprises. This is an overview across both neoadjuvant and adjuvant therapy. You can see the grade 3, grade 4 TEAs very, very similar, slightly higher for atezolizumab for the serious TEAs. In looking at drug discontinuation due to treatment adverse emergent events, they're just a few percentage points higher for the atezolizumab arm than the placebo arm. We do see substantially more discontinuations of the atezolizumab due to treatment emergent adverse events, but we did have fairly conservative discontinuation rules in the study. TEAs leading to death were fortunately rare and no difference between the two arms. This is just a quick snapshot of the overall TEAEs on this graphic. Red is placebo, blue is atezolizumab, light colors are grade 1 and grade 2, and you can see that across the spectrum, most of these were grade 1 and grade 2, where you do see the darker colors. These are things related to chemotherapy like neutropenia, neutropenic fever, so forth and so on. We did not put the immune-related adverse events on this slide, choosing to show them separately here. These are immune-related adverse events, so these were where the investigator said, yes, I believe this was related to my immune therapy. And you can see that this is kind of typical pattern of what we see. The most common are the endocrinopathies, hypothyroidism. We saw infusion-related reactions, but then this smattering of events, some of which are serious, higher grade hypophysitis, nephritis, pancreatitis, and so forth, but certainly in line with what we expected. Nothing new there. So in summary, addition of atezolizumab to neoadjuvant chemotherapy followed by adjuvant atezolizumab did not result in statistically significant improvement in EFS. We had a hazard ratio of 0.8, log rank P equals 0.08. 4-year EFS was numerically higher by about 3% with the atezolizumab. Our control arm we saw the PCR rate of about 57%, which is what we had expected. We improved that to 63%. Our overall safety profile with atezolizumab with multi-agent chemotherapy was certainly in line with known safety profiles in TNBC. And we think that while we did not meet our efficacy criteria for our primary endpoint, our results do support translational studies to try to identify biomarkers to see the subsets of patients who may benefit from this class of agents in this patient population. Thank you very much for your attention.
Thank you, Dr. Gair. Since we are over time, we'll have a room for one quick question and one quick answer. Mic number 4, please.
Samimi, KHCC, Jordan. I want just to confirm that capecitabine was allowed for patients who did not reach complete pathological response?
Correct.
And could that explain the no difference in the outcome? Even there was a significant difference in the complete pathological response compared to Keynote 5224.
Yeah, I mean, we don't have an explanation for it. Like I say, these are top-line results we've been looking at for 6 weeks. A dynamic to that was that early on it wasn't allowed, so the amount of capecitabine usage was dynamic during the accrual and treatment phase, and we're going to look at that to see, if we can tease it out. But, the idea being was did capecitabine in half the patients eliminate the apparent benefit? I mean, that we have to look at. We just haven't had a chance to do that.
Thank you.
Sure. Thank you.
Thank you. Yeah, thank you.
Thank you. I'd like to invite up Dr. Zhiming Shao from Fudan University in Shanghai, China, to speak next about neoadjuvant camrelizumab plus chemotherapy for early or locally advanced triple-negative breast cancer, a randomized, double-blind, phase 3 trial.
Thank you. It's my great pleasure to present in San Antonio Breast Cancer Symposium. Today, I will talk about neoadjuvant camrelizumab plus chemotherapy for early, local or locally advanced triple-negative breast cancer. The trial name is called CAMRELIEF, which is a randomized, double-blind, phase 3 trial. This is my disclosure. We know that triple-negative breast cancer comprises around 15% of all breast cancers, which is the most aggressive subtype with high recurrence and worse survival outcomes. So the long-standing standard therapeutic therapy for early triple-negative breast cancer has been anthracycline plus cyclophosphamide, followed by or preceded by taxane. We also know that dose-dense AC, which we call the DDAC, is also significantly lowers the recurrence and mortality rates. So the cooperation of the plantinine has been shown to improve the pathological complete response rate, a surrogate for long-term survival in large-scale randomized study trial. For example, GP62, CLGB 40603, brightness trials. So the new therapeutic strategies are urgent to needed to further improvement outcomes. So we also know the triple-negative breast cancer is the most immunogenic breast cancer subtype, potentially responsive to added immunotherapy for chemo backbone. Everybody knows right now the Keynote 522 trial is already established the neoadjuvant pembrolizumab plus plantinine-containing chemo as a standard of care for high-risk early triple-negative breast cancer. The chemo backbone, which is paclitaxel, plantinine, tri-weekly AC, also the disease stage is including T1, CN1 to 2, or T2 to 4, and 0 to 2. So the high-risk patients may benefit from a more intensive DDAC regimen. Here we show the camrelizumab, which is anti-PD-1 monoclonal antibody, has demonstrated the robust anti-tumor activity and a favorable tolerability in phase 2 trial in early stage and advanced triple-negative breast cancer. So here we conducted a randomized phase 3 trial to further evaluate camrelizumab versus placebo in combination with platinum-containing DDAC-based chemo as a neoadjuvant treatment for early or locally advanced triple-negative breast cancers with any node status. So here's our study design. The patient's criteria including stage 2 or stage 3 invasive triple-negative breast cancer. The patients including T2 and 0 to 1, T3 and 0 to T2 and 2 to 4 to 3, including T3 and 1 to 3. So the no prior systemic treatment allowed, equal PS 0 to 1, the centrally assessed PD-L1 expression. So the patient will randomizely two groups. The one is the camrelizumab, which is 200 milligram day 1 to QW2 plus non-paclitaxel plus carboplatin followed by DDEC. The placebo group, which is only the chemo, which is non-paclitaxel plus carboplatin followed by DDEC. After surgery, the camrelizumab allowed 200 milligram Q2W up to 1 year and the standard care. The placebo group, which is only the standard of care. So the primary endpoint is PCR. The second endpoint is EFS, DFS, and DDFS, pre-surgery ORR, and safety. So here's the patient's dispositions. 563 patients screened for eligibility. So finally, 441 patients randomized to camrelizumab, which is 222 assigned for the neoadjuvant, going to the final analysis. 219 assigned for the neoadjuvant, which is placebo plus chemo, is also going to the final analysis. So we also analysis the baseline, the characteristics, which is the camrelizumab and the placebo. So we can see here from the age, PD-L1 expression, primary tumor classification, node involvement, clinical staging, the two group is balanced, well balanced. So here are the results for the PCR, which we point as a primary endpoint. So we analysis the overall population and high-risk patients. So for all the patients, primary endpoint, PCR, which is the camrelizumab, 56.8% versus placebo, 44.7%, which is the absolute difference is 12.2%, is the p-value is 0.0038. For the high-risk populations, we divide the stage 3 and node positive. For the stage 3, is the camrelizumab is 49.4% versus 38.0%, which is the difference, absolute difference is 11.4%. However, in the node positive groups, the difference is getting bigger. For the camrelizumab group is 57.8% versus 42.7%, which is going to the high absolute difference is 15.1%. So we also show the subgroup analysis. So here is show the forest analysis. So we can see here, except equal PS on all the patients, the age, node status, even in the positive or no negative clinical staging, stage 2 or stage 3, PD-L1 expressions, all favorable to the camrelizumab. We also analyzed the tumor radiographic response rate before the surgery. So we have analyzed the best overall response, including the complete response, partial response, stable disease, progression disease. Finally, we ORR, overall response rates. So here we can see camrelizumab reached 87.4%, placebo group reached 82.6%. So the difference is around 5%. We also analysis of survival outcomes. So here I show the early trend in the EFS, DFS, and the DDFS all support PCR benefit with the pembrolizumab for the chemo. Of course, we have to waiting for the long follow-up to confirm our results. For the safety summary for the neoadjuvant phase, so we probably can see is the mean treatment for the pembrolizumab and the placebos, any AE, SAE, or immunorelated AE, pretty similar. But for the immunorelated AE, of course, the pembrolizumab is much higher than to the placebo group. So if we take a common AE, for example, blood counts and liver functions, whenever is pembrolizumab is a little high than the placebo. But if we look at immunorelated AEs, for example, RECCP, etc., is much high for the pembrolizumab. But what we understand that is self-related, it will be manageable. So here is the trial's conclusion. This phase 3 trial demonstrated the added benefit of pembrolizumab when compared with the intensive chemotherapy regimen, which we call the non-paclitaxel plus platinum, followed by DDAC, is efficient. So the PCR rates is 56.8% versus 44.7%, which the difference is 12.2%. P-value is significant. For the PCR rates, generally consistent across all the subgroup, including the high-risk categories. For example, stage 3, 49.4% versus 38%, which is node positive, or the node positive, 57.8% versus 42.7%. Also, we found this favorable trend observed for the EFS, DDFS, and the DDFS. Of course, we have to do the longer follow-up to confirm these results. Also, the safety profile was manageable and consistent with the known profile of each agent. So that our data support pembrolizumab plus chemotherapy as a potential neoadjuvant therapeutic options for treating early or locally advanced triple-negative breast cancers. So here I would like to thank all the patients and their family participating in this trial. Also thanks to all the investigators, research personnel, and the staff who conducted this trial. We also like to thank Jiangsu Hengrui Pharmaceutical Company to support this trial. Finally, I would like to thank 2024 San Antonio Breast Cancer Symposium to invite us to present these data. So the data is online today in the JAMA. If there any detailed information, can consult these articles. Thank you very much.
So we'll start with a question from microphone number 3, please.
Thank you very much. Matthew Getz from Mayo Clinic. I have a comment first and then a question. The comment relates to what we just heard from Dr. Geyer a few moments ago, showing that TILs are associated with outcome. My understanding is that TILs have been scored in the Keynote 522, but we don't have the data as of yet. I would encourage the supporters, the organizers, the funders to release these data. We need to see these data. My question for you is, have you looked at the association between TILs and outcome in your study?
Yeah, I know. My presentation will be followed by Dr. Gill, give a little pressure because it's compared to similar trials. And yes, you are right. We probably need to analysis of the TILs to further studies, for the next presentations.
And we only have time for one more question. I'm sorry, microphone 2 was there first, so I'm going to go with microphone 2.
Thank you. I want to congratulate you and your colleagues on the study and you on your presentation. Sykov from Brown University. In both CALGB 40603 and Keynote 522, there was a correlation of drug delivery with achievement of PCR, and for CALGB 40603, there was clearly a correlation between drug delivery and EFS. We've not heard such results from Keynote. Do you have any information about correlation between delivery of your neoadjuvant chemotherapy, particularly the taxane component of it, and achieved PCRs?
Yeah, of course, yeah, you are right. For the delivery, I think they have a certain effect of the PCR, but in these studies, we all use non-paclitaxel. We think in the previous study, non-paclitaxel seems to be more effective than the PCR rates. So we have to analysis for the different administrations. Thank you.
Thank you.
Thank you. And next, we will get to hear a wonderful discussion from Dr. Giampaolo Bianchini from the Vita-Salute San Raffaele University in Milano, Italy.
First of all, I would like to thank the scientific committee for offering me the opportunity to discuss this very important aspect. Is it the end of the beginning of immunotherapy in triple-negative breast cancer? This is my disclosure. Perioperative pembrolizumab combined with neoadjuvant chemotherapy is the standard of care for intermediate high-risk triple-negative breast cancer. The Keynote met the co-primary endpoint of PCR and event-free survival and demonstrated a significant benefit in terms of clinical value and statistical value in the overall survival analysis. I just would like to remind that when we look at the ITT population for event-free overall survival, we should refer to the ITT population for PCR, where the delta is smaller than the interim analysis that drive the primary outcome, is 7.5%. So there was other trial that really support the idea that immunotherapy works in triple-negative breast cancer. Actually, two of these trials failed the primary endpoint, the Capernuevo, the Neotrip. The only one that met the primary endpoint was the Impassion 031. But the long-term outcome in both the Capernuevo and Impassion 031 was positive and really convinced all of us that this is the right way, providing additional evidence to the Keynote 522. So what are the main findings of the two studies that we have seen presented? So the NSABP Gepard-12 trial failed to meet the primary endpoint of event-free survival. On the other side, the CAM-RELIEF met the primary endpoint of PCR. For the CAM-RELIEF, that is the first trial that I'm going to discuss, there was also presented some secondary endpoint with some early indications of potential positive impact of the long-term outcome. But are current results practice changing? I would like to remind all of us that we don't have any evidence that PCR is a surrogate or long-term benefit at the trial level. And like if you look all the trial in terms of delta or PCR, you see that the Keynote 522 in the ITT population compared to the NCB trial has very similar results in terms of PCR. So if you would have used this endpoint to decide, the decision would be the trial seems really similar. But the event-free survival is quite different, as you see. Actually, I use one of the analyses of the Keynote with a median follow-up as much as similar to the NSABP Gepard-12 because of course, for comparability. I would like also to notice that the risk of the population in the control arm of the NSABP Gepard-12 is much lower than the risk of the control arm in the Keynote 522, and we have to keep in mind this because it impacts the power of the study. Also, if you look at the PCR, the CAM-RELIEF seems very similar to the Impassion 031, but we know that neither FDA nor EMA has decided to give a green light to this trial, despite some, we say, interesting results, but not significant in terms of event-free survival. So are the current result practice changing? No. Demonstration of long-term benefit is needed. And also an additional caveat is that only Chinese population want to enroll in this trial. Are the results of the NSABP Gepard-2 practice changing? Of course, no, because the trial doesn't meet the primary endpoint. But I would like to remind that null hypothesis say no difference between the treatment exists. And when a superiority trial is not significant, it is meant that the statistical analysis did not provide enough evidence to reject the null hypothesis. So an incorrect interpretation, it means that the null hypothesis is true and the intervention has no effect. The correct interpretation is that the observed difference could still be explained by chance, and results simply do not support the conclusion that there is a difference between the groups under the study design, the sample size, and the population included. So I would like really to try to look at these elements to see if we can understand why the Gepard-2 is not positive in terms of long-term outcome compared to the keynote. Of course, we start with the trial design. I was just to remind that the randomization is different. This can impact the power of the study. The dose dense was used in the NSABP Gepard-2 in 63.5% of the population, and capecitabine after surgery in roughly 50% of the population. So more chemo. Of course, two different antibody drug conjugates, one anti-PD-L1 and one anti-PD-1. It's interesting because you see more chemo both before dose dense and capecitabine. What there is and what we know about the effect of the chemo? Well, there is this sub-analysis of the keynote that essentially demonstrate that if you give less chemo, the benefit of pembrolizumab remain the same, both in terms of PCR, so there's been more chemo and less chemo, I benefit from immune checkpoint, but also in terms of event-free survival. But on the opposite side, if we consider just the intensity of the chemo, within pembro arm, if you don't receive the full dose, you have less probability to achieve a PCR, and if you are in a control arm and you don't receive the full dose of chemo, you have less chance of PCR. And actually, there is a numerical higher recurrence rate in the patient that don't receive the full course of chemo. So chemotherapy exposure matter, and this should be kept in mind in the escalation trial. So if we look at the patient characteristic and we compare all the trial, of course, with a special focus of Gepard-2 and keynote, we see a difference in the ethnicity of the population enrolled. So essentially almost no Asian population in the Gepard-2. Does this matter? Actually, there is an indication that the amount, the magnitude of benefit in the Asian population of the keynote seems to be larger. So I don't say that the other don't benefit. I'm just saying that the magnitude seems to be higher. That's it. And about the stage, you know, unfortunately, the distinction 1 to 3 centimeter and more doesn't allow me to complete the table, but I can tell you that if you look at the nodal stage, you see that the Gepard-2 and NSABP trial have a higher proportion of node negatives, almost 60%, compared to the keynote trial. There is a positive signal where in node positive and in larger tumor. So to me mean the patient population with the higher risk of recurrence. Something indicating that probably there is a problem in the power of the study. And if you look at the comparison of the type of events, it's quite interesting that no neoadjuvant progression was described in the NSABP Gepard-2 trial compared to keynote. The local regional is very similar, but you have, as demonstrated by the better prognosis, a lower risk of event in the NSABP Gepard-2. But it was noticed, it's very interesting that for non-CNS distant metastasis, you have a reduction of 44%. So a clear indication that you have an activity by the drug, that is not just that it doesn't work at all. About PD-L1, except the Ventana trial, all the other use different tests. You cannot compare the proportion, but it seems that in Gepard-2 NSABP, the number of events of PD-L1 positive is smaller compared to the NeoChip trial. So there is an elephant in the room. Of course, part of the explanation could be that anti-PD-1 and anti-PD-L1 is not biologically the same type of molecule, are similar but different. And I don't know about efficacy. There is not head-to-head comparison. We have to put this in the table as a contribution, not the explanation, the contribution of the eventual minor effect of the trial. But I can also tell you that there is an indication of different activity in terms of toxicity. So this is a very busy slide. It was very difficult to collect the information because not all the trial provide information in the proper way. But the impression that I have, so take as an impression, is that clearly PD-L1 seems to be less, I would say, generating less immune-related adverse events than at least pembrolizumab, for which we have much more mature appropriate data we will see from CamRelief with the full publication. So there are some open questions and some learn that we have. So the first is, in my opinion, now that we can compare trial with Atezo, the Impassion 030, the adjuvant trial with chemo was totally negative, the hazard ratio 1:2, compared to the two trials in the neoadjuvant that, despite not formally positive, clearly demonstrate a benefit. So these support the idea that neoadjuvant immune checkpoint, like in many other solid tumors, is the best way to give treatment. I also would like to stress that in the adjuvant setting, giving chemo plus immune checkpoint biologically is very different in that specific setting without a burden of disease compared to giving monoimmunotherapy. So I'm really looking to see the results of this SWOG trial. It's not probably going to change our practice, but it's very important biologically. There is an outlier in the trial that is the NeoChip. The NeoChip is really, in terms of event survival, a negative trial, despite we demonstrate that by biomarker analysis, you can identify population who benefit. But the question is why? And one, not because it's probably the reason, is we don't use anthracycline. It's the only trial that don't use anthracycline. Of course, can be the reason or not. We will wait the Scarlet randomized trial that is testing whether anthracycline in presence of immune checkpoint are needed. Then I would like to remind all of you that all these trials that we've seen missed the opportunity and missed the population of the year low. The year low patient should be offered because we have evidence for 2 randomized trials and the Promenade that is a large collection of data from France that really demonstrate the benefit from immune checkpoint plus chemo in this population. The last point that I would like to mention are early progression. Early progression are, in my opinion, one of the major unmet needs. And what I call early progression, imagine you give the keynote regimen, 12 months of treatment, 12 months of follow-up, that for me is early progression. How much are this population in the clinical trial? To look, we take the curves, we use a website that allows you to derive the point estimation if it even is not demonstrated. Essentially, we was looking which is the proportion of the event that you have in the first 24 months, early progressor, compared to the progression that you have later on. And you see in green the area that you observe as a 2 time point. Well, it's much more than you think. So the majority of the patients have an early progressor, so we really need dedicated trial for this patient. And really, finally, the idea is We have created the first generation of the trial in a one-size-fits-all method. We should really start to think in a different way. It's not just a matter of predictive biomarker of benefit for immunotherapy, but as was mentioned before with TILs and other biomarker, of course, if a patient do well, it's not just worthy to give something else. So we need biomarker to select in a better way the patient population. And actually, another strength of the NSABP GEPARDUS trial is really the large connection of sample for potentially two biomarker analysis. Now, this is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. And I would like to thank the authors that I tortured with my question by email. They reply. And my colleagues, Luca Licata, Barbara Galbardi, and Marco Mariani for helping me in the presentation. Thank you very much.
Thank you so much. The end of the beginning indeed. And so we will now be moving on to another abstract presentation from Dr. Paula Gonzalez-Erickson from Vanderbilt-Ingram Cancer Center in Nashville. And she will be presenting on in situ detection of individual classical MHC1 gene products in breast cancer, identifying gene and subtype-specific biased antigen presentation loss.
Okay, so I'm going to switch gears on all of you a little bit here and talk about analytical development of biomarkers, which I understand is not as exciting as the clinical trial results you've all just heard, but it's really important. It's important for us to know exactly what the assays that we use are detecting to have successful companion and complementary biomarkers, and also to really understand the biology behind clinical decision making. So I want to thank the organizing committee for inviting us to present this work. I have no financial disclosures. So I'm going to start with a little background on why, in particular, MHC1 or class 1 expression can be a little bit of an elusive biomarker. So there are three classical class 1 molecules, HLA-A, B, and C, that are expressed on most nucleated cells and function through antigen presentation to T cells and inhibitory regulation of NK cells. Downregulation or loss of class 1 is a well-known mechanism of immune escape for cancer cells and has been mechanistically associated with resistance to immune checkpoint inhibitors in breast and other cancer types. Therefore, at least some class 1 expression is required for effective response to immunotherapy. Moreover, cancer vaccines that have mostly failed in the breast cancer scene require both the carriage of the allele by the treated patient as well as the expression of the HLA peptide complex on tumor cells. The latter is generally not verified in clinical trials. Immunohistochemistry, either chromogenic or fluorescent, is an easy way to measure tumor-specific class 1 expression, since it allows the differentiation of the tumor and stromal compartments. Unfortunately, due to the highly polymorphic nature of the genes that encode for these proteins and changes in the quaternary structure that happen after formalin fixation, like the dissociation of the heavy and beta-2 microglobulin chain, detection by IHC can be a little bit complicated. Moreover, only a few commercially available antibodies recommended for IHC use have been characterized to really determine their specific recognition of HLA-A, B, or C alleles. So to more effectively characterize allele-specific recognition of commercially available antibodies, we used K562 cells that do not express MHC1 in their surface and transfected them with one of 16 HLA-A, B, and C alleles listed here. We then constructed a tissue microarray and stained with these commercially available antibodies. We found that most antibodies stained a wide range of HLA-A, B, and or C alleles despite vendor specifications. But we identified and validated a true pan-HLA-A-B-C clone as well as specific HLA-A, B, and C antibodies. As proof of utility, we stained a series of archival samples from 175 patients with HER2 negative stage 1 to 3 breast cancers and 24 intermediate to high-grade ductal carcinoma in situs from a repository at our institution. Although the detection of other alleles that we didn't test is unknown, we corroborated class 1 expression on non-tumor cells surrounding as a positive internal control. So we identified single, double, and triple molecule loss. Of note, the pan-HLA-ABC clones only detected the loss of all 3 molecules, but failed to detect instances of single or double molecule loss. This would result in 67% of cases with loss gone undetected when using a pan clone. So within the invasive carcinoma samples, we observed subtype-specific bias patterns of loss. So the hormone receptor positive cohort showed higher occurrence of HLA-A and B loss, whereas the triple negative showed a more uniform distribution of loss across all 3 molecules. The hormone receptor positive cohort showed higher rates of total loss for HLA-A, B, and C in any combination than TNBC, and this difference was driven by loss of HLA-A and B. In contrast, the triple negative patients showed higher rates of conserved expression for each single molecule and the combination of all 3. Samples from DCIS showed a pattern of loss that was more similar to the hormone receptor positive invasive cancer, regardless of their hormone receptor status, both showing prominent A-B loss and no single molecule C molecule loss. The main difference between the invasive and DCIS was that DCIS showed lower rates of total C loss, while HLA-A and B loss were early events prevalent in DCIS. So our study only tested 16 alleles, which is a major limitation. Future work will expand on the allele and molecule specificity evaluation. However, the alleles that we tested are among the top 10 most commonly expressed alleles in the general population. We identified and validated PAN and HLA-A, B, and C specific clones. These molecule-specific clones enable a more granular assessment of class 1 downregulation, providing insight into the individual molecules that are downregulated and contribute to the net PAN signal. Additionally, the double and single molecule losses that we observed would have gone undetected if using a pan-HLA clone. While at the gene level, alterations in HLA-A have been shown to be more common than those in B and C, at the protein level, we observed that HLA-A, B, and ABC loss were more common than single molecule loss. This, coupled with this subtype-specific patterns that we observed, hints at a paragenomic mechanism of MHC1-specific gene silencing that could be related to cancer cell transformation, a differentiation status, or cell of origin. We demonstrated the novel finding that HLA-A and B loss are early events prevalent in DCIS. Although the findings are underpowered due to the small number of samples stained, they suggest a potential founder effect. Even though the consequences of individual class 1 loss molecule and anti-tumor immunity are currently unknown, these findings enable the potential of HLA-A, B, and C expression as an immunotherapy response modifier or predictor. And given the differential role of HLA-C on NK cell regulation, could better inform future immunotherapy drug combinations such as those that target T and NK cell function. Moreover, this data could also inform cancer vaccine clinical trials. These have mostly been using HLA-A-restricted epitopes, and we have shown that over 50% of early-stage breast cancers lack any HLA-A expression. So I want to thank all the authors, our collaborators, the founding institutions, everyone in the lab, and thank you for listening.
Question at microphone number 1.
Shireen Lloyd, Peter Mac in Melbourne, Australia. Congratulations, that was really lovely. Did you correlate your findings with tumoral immune infiltration at all? Or grade, for example, grade 3?
Yeah, we did. We did look at TILs, and there was no correlation in either the hormone receptor positive or the triple negative cohort. The triple negative cohort is mostly residual disease post-neoadjuvant chemotherapy, so that may explain why we didn't, while others have previously found a correlation with just the pan-HLA-ABC. We did, however, also do CD8 staining on a subset of the triple negative cohort, and we saw an association with intratumoral TILs. Intratumoral CD8s, or the location of CD8.
So loss was associated with more TIL. Am I understanding it correctly?
Loss, yes. No, yes, higher expression of class 1, either A, B, or mostly A and B, associated with higher CD8 in intratumoral CD8s.
Thank you.
Thank you. And microphone number 4.
Adelaide, Australia. It would take 2 hits, but did you look at loss of beta-2 microglobulin, which would abrogate all class 1?
We didn't look at beta-2 microglobulin specifically. We were actually kind of interested in looking at it, but we didn't, sorry.
Wonderful. Well, thank you, and perhaps that'll be some food for future thought. Thank you. And we will move on to Dr. Abdel-Razeq, who is going to present on a study of multimodal integration of real-world clinical and genomic data for the prediction of CDK4/6 inhibitors outcomes in patients with hormone receptor-positive, HER2-negative metastatic breast cancer. And Dr. Razavi is from Memorial Sloan Kettering Cancer Center in New York.
I would like to thank the organizers for the invitation. It's truly a pleasure to present our work on use of machine learning in predicting the outcomes on first-line CDK4/6 inhibitors. These are my disclosures. So the use of CDK4/6 inhibitors have completely evolved our practice and improved the outcomes for our patients. But there's extensive amount of heterogeneity in the outcomes of the patients. As we know in clinic, there's a group of patients who derive no benefit from addition of CDK4/6 inhibitors or endocrine therapy, and there is a group of patients who do outstanding well, remain on these combinations for years. And as the INAVO 120 clinical trial clearly showed, there is a need for escalation of care in a group of high-risk patients, and when this happens correctly, it improves the outcome for the patients. So in this clinical trial, as you're aware, they use the measurable disease and treatment-free interval of less than 1 year as a marker of poor outcome, and also they use the PIK3CA as a biomarker for the triplet. And it improved the outcomes, but what is clear is that at the end of the day, there was a group of patients who did remarkably, they didn't do well and they had progression early, but then after that, the cares followed each other. The question is, can we do better and identify the patients better for such escalation therapies? And there's been significant amount of work from our group and others have shown mechanisms of response and resistance to CDK4/6 inhibitors. This is not like 2015, we didn't have much knowledge about CDK4/6 resistance. We did know about RB1 loss, but now we know much more. We can explain more than 50-60% of resistance to CDK4/6 inhibitors based on the genomic features of the tumor at baseline. So can we use also this information to do better? So now, can we combine the clinical data that we are now collecting from all the patients and also genomic data and improve on the traditional risk methods and models that we've been using here? And we put together a program at MSK specifically for this purpose. We are trying to use machine learning, AI, to predict the outcomes of the patients. We're also collecting extensively biomarkers and tumor tissue from the patient and ctDNA from the patients to identify also the mechanisms of resistance. Can we forecast the mechanism of resistance to this for the patients as well? And that helps us and inform the treatment escalation, de-escalation paradigms for the patients. So here I'm just going to present the data on the use of genomics at baseline and clinical data and on the prediction of outcomes and progression-free survival on the first-line CDK4/6 inhibitors. So we used our MSK breast cancer translational program data. We included only the patients who received CDK4/6 as the first line. We limited the analysis to the patients who had tumor sequencing at the time of diagnosis within 3 months from start of CDK4/6 inhibitors or before, so the post-progression samples were not included. The final cohort included 1,087 patients. We made a split of 70-30. The 70% of the patients were used for the training and the rest were used for the test set. And there was and then we used permutations to make sure that these are balanced. We utilized OncoCast machine learning framework for the predictions with 100 iterations and threefold crossovers, and the holdout test was used to test the performance of the model. So these are the clinical features of the patients. I would like to highlight that, consistent with what we see mainly in the tertiary specialized cancer centers, the cohorts are at a higher risk than what we see generally in clinical trials or in practice. Outside these centers, we had more premenopausal patients, higher number of patients with TF5 less than 1 year, many patients with visceral disease, liver disease, so on and so forth. And that was reflected in the progression-free survival of the cohort, but there was complete balance between the features in the training and test set and also in the outcome for the patients in the training and test set as well. These are the genomic features of the patients. Again, consistent what we expect in the metastatic breast cancer, 27%, 30% risk P53, MDM2, higher rate as from expected from RB1. We usually expect around 1 to 2% in the pre-treatment treatment CDK4/6 naive patients. Also, we found MYC, P10, so on and so forth. Majority of the patients in this cohort, more than 90%, the first metastatic biopsy was used for this analysis. And at the end of the day, the features, genomic features, was very balanced between the training and test set. We only included the genomic alterations that were OncoKB annotated to decrease the amount of noise from the genomic data. So these are the results. This is the clinical model. As you can see, the clinical model is doing a great job stratifying the patients. In the higher risk group of patients, the median progression-free survival was 6.3 months, and the hazard ratio was 3.95. This was highly significant. And then we asked, what are the features that the machine is picking up? And these are the ones that, as a clinician, when you look at it, it connects to us. We go to clinic, we see the patients. There is a feeling when we see the patients that she's going to do well or she's not going to do well. And a lot of these reflects that feeling when we go to the clinic. Liver metastases. This is a patient who had a short TFI. She has a low TFI. PR was negative in the metastatic disease or in the primary tumor, had visceral disease, younger age, so on and so forth. And here in the heat map, I show it, based on the patients are ranked by the risk based on the model, and you see the higher risk patients here reflect the same thing. This is the genomic data model, and you see that in the genomic model, similarly, there was a good stratification. And genomic features also reflect the biology of the disease and what we know about CDK4/6 resistance with P53, alterations in the RTK-MAPK pathway, high TMB. We heard yesterday from Avantika about the APOBEC resulting in resistance. Similarly here, high FGA reflecting the copy number complexity of the tumor, and also higher percentage of LOH. These are mainly, some of them, majority of them are HRD tumors also associated with worse outcome, and also some of the other bad players like P10, so on and so forth. But then the power of the analysis was when we combined this data, and you can see that the model performed significantly better than the clinical or genomic model alone. We were able to identify 4 categories. There was an intermediate low and intermediate high risk group as well. But when we look at the high risk group, now the median progression-free survival is 5.34 with a hazard ratio of 6.45. And then these are the features that the model is picking up. I'm just highlighting some of them here. Again, you see the clinical features such as liver metastases, DFI, PR negativity, P53 mutation, high TMB, so on and so forth, are associated, whole genome duplication, and also a lot of the clinical factors are also being picked up by the model to predict the outcomes. These are the performance of the model in the test set. It's almost identical with overlapping Kaplan-Meier curves in the low-risk group to high-risk group. Here in the test set, the high-risk group patients had a median progression-free survival of 3.9 compared to 5.3 in this large data set. And as you can see here, the hazard ratios also mimic each other perfectly, and there was no statistically significant difference between what we saw in the test set compared to the training set. So does this model improve in what we have been using in our design of clinical trials? That's a major question because we are designing multiple major phase 3 clinical trials based on TFI, based on DFI, based on these established algorithms that we have for identifying the high-risk patients. Can we improve on that? And as you can see, the traditional model is doing a perfect job. It's a very, very good job separating them well, but can we do better? And what I'm showing here is the high-risk group of patients and low-risk group of patients based on the traditional conventional clinical model. And as you can see, there is a significant separation of the curves when you look at the high-risk and low-risk group of patients. And what I would like to highlight is that the opportunities that we miss here, for example, so in the low-risk group that were not considered for the clinical trials for escalation in the first-line setting, 20% of the total population were considered to have high-risk or intermediate high-risk disease with rapid progression, with the median progression-free survival of 5 or 9 in this group. This is 27 patients of the patient in the clinical low-risk group. And also in the high-risk group, there were 89 patients, 32% of those patients that were considered to be low-risk based on what we had. One of the powers of this analysis and such models is that we can have individual patient predictions. So what I'm showing here is just the cumulative data for progression, probability of progression in less than 6 months and less than 12 months. And as you can see in all of these predictions, the mixed model is outperforming the clinical only and the genomic only model, as well as the conventional model that is based on measurable disease and TFI. Then we looked at the actionable alterations. Are there any changes in the rate of actionable alterations by increasing the risk? As you can see here, there was no significant change. This has been shown by us and others, and also analysis of the clinical trials that the PIK3CA mutations are not associated with outcomes at baseline in the CDK4/6 treated patients. But there was increase in the actionable alterations with the increasing risk. You see here P10, ESR1, ERB2 mutations increase, and these are all considered to be targetable, actionable alterations that can be utilized in the escalation therapies and escalation trials in this setting. I would like to also highlight the increased rate of somatic BRCA1 and 2 mutations. Our analysis did not include germline variants, but we have shown that the somatic and germline BRCA mutations and HRD is significantly associated with worse outcome. It was very interesting that our model also picked up this in an unsupervised manner, and as you can know, this is now under study to see if the first-line PARP inhibition compared to the first-line CDK4/6 inhibition can improve the outcomes for the patients in this group of patients. So there is a phase 3 clinical trial ongoing, and hopefully we get some answers in this group. But what was very striking was a significant increase in the rate of P53 mutations as the risk score was increasing. There is almost a linear increase in the prevalence of the P53 mutations in these patients, with a high-risk group of patients having a 75% P53 mutation. And as you can see, this was consistent across. This potentially can provide an opportunity for us. I would just like to highlight the work that was done by our group, led by Ray Kudo in Sarat Chandra-Padi's lab, looking at the P53. We all knew that P53 is a prognostic marker, but is it also a predictive marker in this setting as well? And the work very clearly showed that P53 through P21 and CDK2 interacts with the dream complex assembly and then results in the cells to bypass the G1 arrest and go to the G1S phase. And what was significant was that we have now multiple CDK2 inhibitors in development, and we were able to show that addition of the CDK2 inhibitors to CDK4/6 inhibitors in group of P53 lost tumors can improve the outcomes of the patients, as is shown here. So I would like to just mention some of the future directions of the work. We are undergoing, we would like to have an external cohort for a validation of this and then to test the robustness and generalizability of the model. We are committed to develop a practical single patient outcome predictor based on maximal parsimony so that we have the minimum amount of clinical and genomic data included. Hope that we can validate this model as well. We are including baseline ctDNA genomic and ctDNA genomic features in this because many of our patients now are going to have first line before treatment ctDNA testing. And in our analysis that was just presented by Luc Cabot as a poster here, ctDNA fraction and amount of ctDNA is also a good prognostic marker, good predictive prognostic marker. So hopefully we can also identify this as develop this model further as well. And the future is upon us. We're going to have AI as part of our EMR, so on and so forth. We are also using multimodal large language models for integration of the pathology images, radiology images, as well as the comprehensive genomic and clinical data to predict the outcomes. So in conclusion, we developed and tested the machine learning algorithm to predict the outcomes. The mixed clinical genomic model outperformed the clinical and genomic models. The key predictive clinical features and genomic features were those that were biologically and clinically plausible. There was the increased prevalence of targetable alterations, BRCA1, 2, P10, ESR1, P53 in the high-risk group of patients. And I would hope that we can see these type of models in adaptive clinical trials for escalation and de-escalation for our patients. So I would like to acknowledge the people who did the work in our MSK translational program, Enrico Moiso and Emanuela Ferraro, who led the work, and also Sarat Chandra-Padi and his lab for the work that they did on the P53 and also all the advice on performing the analysis, and also our MSK Global Research Program and all of my colleagues at MSK. Our patients and their families, our patient advocates who are very much involved in our research, our funding sources, and you for your attention. Thank you.
And we have time for just one question from microphone number 2.
Thank you, Saikov from Brown University. I want to congratulate you and your colleagues on this work and you on your presentation. And I want to thank you for paying attention to try to identify markers of activity or lack of activity for the CDK4/6 inhibitors. And I would have to assume that you can extrapolate that if a patient has a tumor that wouldn't benefit from the addition of a CDK4/6 inhibitor in the metastatic setting, that same person is unlikely or not going to benefit from the addition of a CDK4/6 inhibitor in the adjuvant setting. And I think that one of the most pressing needs that we have in breast cancer right now is to identify which patients might benefit from the addition of a CDK4/6 inhibitor in the adjuvant setting. You know, plastered all over this meeting are ads from a company that recently got a drug in that space approved, trying to expand the use of this class of drugs in lower risk patients. So we have to identify which patients won't benefit and which patients can't benefit by their tumor biology, given the toxicity, often mild to moderate, but occasionally life-threatening, and the cost of this treatment to the patients and to our society. So again, I really want to thank you very much for doing this work and urge you to continue it.
Thank you.
I'd like to invite now our last abstract presenter, Dr. Brooke Felsheim, from the University of North Carolina School of Medicine at Chapel Hill. And Dr. Felsheim will be presenting on paired DNA and RNA analysis of CALGB 40603, the Alliance, revealing insights into the molecular and prognostic landscape of stage 2 and 3 triple-negative breast cancer.
Hello, everyone. Thank you for having me. Today, I am excited to present the paired DNA and RNA analysis of the CALGB 4603 clinical trial on behalf of my co-authors. For stage 2 to 3 triple-negative breast cancer, which represents the majority of TNBC cases, the current standard of care is typically the KEYNOTE-522 regimen, which consists of 4 chemotherapies plus an immune checkpoint inhibitor. Not only is this an expensive treatment, but it is a very long regimen that can have a lot of negative side effects. Not all patients may need to be receiving this many drugs and could benefit from prognostic tools that help to tailor treatment. In this study, we were interested in performing multi-feature prognostic analyses using RNA, DNA, and clinical features to see if and how this may be valuable to precision medicine efforts. And to answer this question, we used data from the CALGB 4603 phase 2 clinical trial, which enrolled patients with stage 2 to 3 TNBC and was a 2x2 factorial design that tested the effects of adding carboplatin or bevacizumab to neoadjuvant anthracycline taxane-based therapy. The primary endpoint of this trial was pathologic complete response, and the addition of either carboplatin or bevacizumab was found to increase PCR rates. However, the addition of either carboplatin or bevacizumab did not increase event-free survival, the secondary endpoint of this study. Given that there was no survival difference between the arms of the study, we combined data from all arms and used this as a dataset resource of patients with stage 2 to 3 TNBC who received chemotherapy but no immune checkpoint inhibitor. For 238 patients in this dataset, we have paired long-term outcome data, pretreatment RNA-seq data, and pretreatment DNA-seq data from a targeted 1,037 gene panel. We are newly presenting the pretreatment DNA-seq data from CALGB 4603 and show its somatic mutational landscape here. Of note, as previous TNBC studies have shown, we see that most samples have a somatic TP53 mutation. And interestingly, we found that a few mitochondrial genes included in the targeted panel were among the most frequently mutated. Furthermore, we calculated the pathogenic germline and somatic oncogenic mutation status of BRCA1, BRCA2, and PALB2 genes and combined this into a single homologous recombination deficiency gene mutation feature, and found when we added this amongst the somatically mutated genes, this was the third most frequent feature overall, mutated in 15% of our samples. However, mutations in the homologous recombination deficiency genes, when considered either individually or combined, were not associated with pathologic complete response, event-free survival, or overall survival. And using these data from CALGB 4603, our objectives were to provide a comprehensive molecular characterization of the paired DNA and RNA-seq data, and to perform exploratory multi-omic prognostic analyses of stage 2 to 3 TNBC. We did this by training survival models using clinical RNA and DNA features from CALGB 4603 and evaluating them on independent data through a workflow which I will explain in more detail. And as I just mentioned, our input feature space consisted of DNA, RNA, and clinical features. So for DNA, we considered somatic mutations and copy number alterations with visualizations of each of these data types in CALGB 4603 shown here. More specifically, for our model, we included somatic gene-level mutations and recurrent TP53 somatic mutations, as well as gains and losses of chromosomal segments known to be important to cancer, including whole arm regions. And the second type of feature we considered was RNA, and we included this as a large set of gene expression signatures that are associated with immune cell types, tumor cell states, and signaling pathways, among other biological patterns. And finally, we trained survival models using the clinical feature of tumor stage, which is already a known prognostic feature. We expect our models to always select this feature, and included it because we're not trying to replace what is clinically used, but build upon it. And then using the entire input feature space I just described, we are trying to predict overall survival as a function of time and event. The type of model we chose to train was a Cox proportional hazards model with elastic net regularization because it is an interpretable survival model that can help select relevant features while reducing overfitting by encouraging smaller coefficients. We trained this using a sequential bootstrapping technique to select our optimal regularization parameters. And we built one model for each combination of input feature type for a total of 7 models. And then we evaluated our 7 models on new unseen samples from patients with stage 2 to 3 TNBC receiving chemotherapy but no immune checkpoint inhibitor, which we gathered from 3 publicly available data sets, TCGA, Metabrick, and Fudan University Shanghai Cancer Center, that also have paired DNA, RNA, stage, and overall survival data. And in total, we have 380 test samples. And here are our results shown as a matrix where the rows are the 7 models that we trained. Across these models, we started with over 2,000 input features, but only 11 total were selected across these models, shown as the columns of the matrix, and colored by clinical, DNA, or RNA feature type. For each feature that was selected by a model, it is colored by its association with worse outcome in red or better outcome in blue. And the corresponding C-index or concordance index of each model in our test data is shown on the right, where higher values are more prognostic and a perfect prediction is 1. And since this is a lot of information, I will highlight the important components. So first, at the top, we have our clinical-only model. This represents our baseline model as tumor stage is already considered prognostic and is used clinically for decision making. This model has a C-index of 0.63 in our test data. Underneath, we see that when we train a model with only DNA input features, none are selected. When we train a model with only RNA features, though, 6 features are selected, and this model has the same C-index in the test set as the clinical-only model. Therefore, RNA features appear to be prognostic on their own in our test data. And then looking at the models with all other combinations of input features, we do see that DNA features were selected when clinical or RNA features were also included in the input training space. And these could have some survival importance, but when we look at each model with DNA and compare it to the equivalent one without, we see that the model C-index does not improve. And so this, combined with the fact that when we trained a DNA-only model, none were selected, makes us conclude that in our data, DNA features don't appear to have too much survival importance. On the other hand, when we combine clinical and RNA features, the test set C-index is higher than it is for the clinical-only and RNA-only models. And prognostic models with these 2 input feature types appear to be the most interesting for future investigation. And here's the clinical and RNA model in more detail. So in addition to tumor stage, the model selected 7 RNA features from an input feature space of over 700. Yeah, this is shown on the left here. The magnitude of each feature's associated scaled coefficient value corresponds to its relative contribution to the model risk score. So tumor stage is contributing the most to the model, as we might expect, followed by the IgG signature. And notably, we see that among the selected features are multiple RNA signatures associated with B-cell and T-cell activity, as well as an RNA signature associated with the HER2 amplicon. And when we apply our full model to our independent test data, we get predicted risk scores that we've split by tertile into low, medium, and high-risk groups and plotted the overall survival proportions over time. And visually, we see that this stratifies the overall survival proportions. In conclusion, in the new targeted panel, DNA sequencing data that we're presenting, we see observations of a high TP50 mutation rate, among many other characteristic features of TNBC from other previous studies. And additionally, though we included many DNA features in our survival analyses, these didn't appear to be too important in our data. And the most promising survival model appeared to be a combination of RNA signatures and tumor stage, and included features of B cells and T cells. However, further work and validation is still needed before creating a molecular predictor that is appropriate for clinical use. I'd like to acknowledge everyone who contributed to this project at all stages. Thank you to the Alliance for Clinical Trials in Oncology, our sources of support, and of course, all individuals who donated tissue to this study. And thank you for your attention.
You stunned them into impressed silence. I see a question at microphone number 5.
Andrew Tutt, Institute of Cancer Research and King's College London. Thank you, a beautiful study. You mentioned at the beginning the important proportion of patients who had germline or somatic changes in HR genes. As we well know, there are a larger group who have silencing of those gene loci that causes DNA repair defects. Have you been able to study that as a feature in your analysis, perhaps through looking at silencing of the transcripts in the RNA-seq data or by methylation analysis, and how that might contribute to any of the other analyses or features that you described?
Thank you for your question. We did not have associated methylation data for this data set, so it's hard to answer questions that are associated with silencing and methylation data for these HR-related genes. Though, of course, we did look at the BRCA1, BRCA2, and PALB2 mutations. And additionally, since this was a targeted DNA sequencing panel, we didn't have the resolution to calculate more comprehensive homologous recombination deficiency scores as is done in a lot of other DNA sequencing data. But of course, this would be very interesting to look at and consider if we had the data to do this, and we'll definitely keep that in mind for.
I guess what I was wondering was whether in the RNA-seq, because if you have epigenetic silencing, you'll see those genes silenced at the RNA level. So you would have you'd see very low levels of BRCA1 or RAD51C transcript as a measure of that epigenetically silenced HR gene population. Is that a feature you've looked for, or maybe it wasn't important?
I see. Yeah, so we didn't actually look at this in the RNA sequencing data, but that is a great suggestion, and we will definitely look into that, and maybe we can discuss more. Thank you.
Wonderful. And just briefly at microphone number 2.
Francis from Peter MacCallum Cancer Center in Melbourne. Given that TILs, tumour-infiltrating lymphocytes, add additional prognostic information to stage in triple-negative breast cancer, have you looked at incorporating the TILs with the clinical stage and then seeing how much extra information your RNA features add?
Thank you for your question. This analysis was actually performed in a paper published by Shepard et al. From this data set, and they found that TILs in the CLGB data or 4603 data was prognostic, but the RNA immune-associated signatures outperformed the TILs in terms of prognostic performance. So we didn't include this in our analysis for that reason, combined with the fact that we don't have TILs data on all of our test data, so we couldn't include it as a model feature. But thank you so much.
Thank you very much.
Thank you.
And now we'll close out our morning with a wonderful discussion from Dr. Fred Howard from the University of Chicago.
Hello, everyone. I'm excited to be here today to discuss these last 2 studies that show us how we might be able to personalize treatment with computational genomic models. These are my disclosures. So we saw these 2 studies today. One predicting risk of progression on endocrine therapy with CDK4/6 inhibitors, and the other predicting survival for early-stage triple-negative breast cancer. Both of these studies used a machine learning approach called ElasticNet. And this is a technique that allows you to select a small number of important features from a large pool of possible variables. For example, Felsheim and colleagues considered over 2,000 RNA signatures, DNA mutations, and copy number variants in their model, and they used this elastic net approach to cut down on the uninformative features, resulting in a model with just a few features that is also highly interpretable. We can get the same hazard ratios or odds ratios that we're very comfortable in working with. The downside of this interpretability is that compared to more complex, like deep learning models, this type of approach doesn't automatically account for interactions between the different variables. Nonetheless, these two studies raise a few important questions. One, can we use machine learning on clinical and genomic data to improve risk prediction over standard approaches? And if so, how might these models be incorporated into current practice to improve care? First, let's think about hormone receptor positive metastatic breast cancer, because I think in the first line setting, there's this sort of dilemma. On one hand, we've seen studies such as SONIA, where for some patients, outcomes may be similar whether you receive a CDK4/6 inhibitor in the first or second line setting. So there may be those receiving such treatment for years and all that associated toxicity without much benefit. On the other hand, as we saw earlier, there's a group that's definitely at risk for early progression. And clinically, we often refer to this as endocrine-resistant breast cancer. And this can be defined as primary resistance, where recurrence occurs within 2 years of adjuvant endocrine therapy, or secondary resistance, where progression occurs within a year of stopping endocrine therapy. And indeed, these groups are at risk, and treatment intensification makes sense, whether it's with triplet therapy with a PIK3CA inhibitor or with other strategies. But can we use other factors beyond these clinical features to predict risk? In the clinic, the thing I think of frequently when I'm thinking about resistance to endocrine therapy is even just hormone receptor status, whether it's assessed on biopsy or with other approaches like FES PET. Now, on reporting of the actual percent expression is a little bit limited in trials, but it's definitely prognostic, and we see in studies like PALOMA-3, the risk of progression at 6 months on fulvestrant and palbociclib doubles when you go from the group with high estrogen receptor expression to the group with low expression as measured by H-score. Maybe we can use gene expression profiling to predict risk. We saw from the Mona Lisa trials that there's a group of patients with basal-like disease who are at risk for early progression on endocrine therapy, whether or not they receive ribociclib. There are a number of genomic alterations that arise on treatment with CDK4/6 inhibitors, including TP53 alterations, like we just heard. However, when we look at data from large trials, most of these pathways are not consistently associated with intrinsic resistance or very short durations of response to endocrine therapy with CDK4/6 inhibitors. So maybe it's not just the presence of a single mutation. Maybe you need to look at a combination of factors. And that's exactly what we saw today. Razavi and colleagues used a cohort of over 1,000 patients from a single institution treated with first-line endocrine therapy and a CDK4/6 inhibitor. They trained a model on 70% of this data and identified a number of clinical and genomic features that predicted risk. And these features make sense. We see things like primary and secondary endocrine resistance, PR negativity, and genomic features like related to tumor mutational burden and TP53 mutations. They found that this clinical and genomic model improved risk prediction over clinical or genomic factors alone. And what's more is when we look at the high-risk groups identified by this model, the risk of progression is indeed very high. It's about as high as any other single clinical or genomic group that's really previously been described. But more importantly, as Dr. Razavi highlighted, is when we look at the proportion of patients in these high-risk groups, as indicated by these orange bars, we can see that with this clinical and genomic model, we can identify more patients at risk. When we look at the conventional criteria of a short treatment-free interval and measurable disease, 50% more patients are identified at risk when we use the high and intermediate high-risk groups from this clinical genomic model. But it doesn't just identify more high-risk patients. It may be able to better stratify this group of endocrine-resistant disease, as about 1/3 of patients are then reclassified into lower-risk groups and indeed had better outcomes. So with this kind of clinical genomic model, we may be able to both identify more high-risk patients that may need treatment escalation, as well as better stratify endocrine-resistant cases to avoid overtreatment. How might we see this kind of model incorporated into care? Well, I think this approach might be able to better select patients who need upfront treatment with PIK3CA targeted, PIK3CA pathway targeted drugs as compared to this conventional criteria of endocrine resistance. Maybe this kind of triplet therapy could be reserved for patients that are high risk by this clinical genomic model. As Dr. Razavi described, maybe CDK2 inhibitors could improve outcomes in the subset with TP53 alterations. Perhaps we could use oral SERDs or other novel endocrine therapies in cases with an ESR1 mutation or other mechanisms of endocrine resistance. And we just saw data on Wednesday of activity of oral SERD in the first-line setting in patients with endocrine-resistant disease. And I think it's also interesting when we look at the factors identified by this model, there was a group that was identified based off of genomic instability, high tumor mutational burden, and low hormone receptor expression. And maybe there's a subset of those patients that would benefit from earlier treatment with immunotherapy or chemotherapy, antibody-drug conjugates, and these approaches are under evaluation in some studies. Could we apply similar machine learning techniques to better personalize the treatment of early-stage triple-negative breast cancer? Well, for decades, it's been recognized that one of the most important prognostic factors for triple-negative disease is the presence of a lymphocytic infiltrator, TILs. We know that TILs predict response to chemotherapy, immunotherapy, and there may be a group of patients with very high TILs that do well without any adjuvant treatment. However, quantification of TILs remains challenging despite all the efforts to standardize assessment. The study to the right shows data from 32 pathologists that read 60 cases to assess TILs, with each pathologist represented by a row and each column representing a different slide. And you can see that the assessment can really vary. For example, with the one case highlighted, one pathologist scores as 70% TILs and another is 0%. This is kind of a cherry-picked example, but I think you get the picture that there can be definite variability in assessment. Additionally, another challenge is that not all lymphocytes are the same. You can have cytotoxic T cells, helper T cells, B cells, and many different immune cells that can be difficult to distinguish visually. However, gene expression profiles may be able to identify the exact combination of immune cells that are most associated with outcome. One signature in particular to consider is this IgG signature that was developed by the Peru lab that quantifies genes related to immunoglobulin production. And indeed, cases with high expression of this signature had higher proportions of plasma cells and lower proportions of inhibitory M2 macrophages. And this signature has been associated with response to therapy in multiple trials of early-stage triple-negative disease. But could we go beyond even these individual signatures? Maybe we could combine two signatures to better identify the most important immune cells. Or maybe you could combine other DNA features that are important for prognosis. Felsheim and colleagues were able to accomplish this by curating a very impressive data set of over 200 patients with paired RNA and DNA sequencing from the Alliance 40603 study. However, they found that DNA mutations and copy number variants were not independently predictive. So their final model consisted of stage, RNA signatures, predominantly immune gene signatures like the IgG signature we just discussed. And they found that this model predicted survival in 3 independent cohorts of early-stage triple-negative breast cancer and was able to identify a group with low-risk disease and favorable survival outcomes. I do want to highlight that there are other approaches in development combining clinical factors and gene signatures to predict risk in early triple-negative breast cancer, in particular TNBC-DX, which is a combination of an immune gene signature, a proliferation signature, tumor size, and nodal stage. The immune gene signature in this assay is very similar to the IgG signature we discussed. It has many of the same genes, and they're very correlated. And like what we saw today, this approach can also predict response to therapy as well as survival across multiple studies. So going forward, it'll be important to compare these different approaches and see whether the combination of signatures we heard about today or this assay or others can best predict survival. And as we're able to do that, we're going to be able to improve the personalization of early-stage triple-negative disease as we can increasingly identify a group of patients with better prognosis that may benefit from less intensive treatment approaches. There are studies looking at observation alone for small triple-negative tumors with very high TIL infiltrates. There are a number of studies looking at less aggressive treatment approaches, including shortened duration of chemoimmunotherapy, a short course of treatment with an antibody-drug conjugate, or even chemotherapy alone without immunotherapy for patients with better risk, either by TILs or clinical risk profile. And we could imagine this type of clinical genomic model may more precisely identify the best risk patients for these de-escalated approaches. For other patients who don't meet these low-risk criteria, we'll continue to hear about optimization with further advances in the chemotherapy backbone or incorporation of more effective antibody-drug conjugates. I think the other really important lesson from these studies is when we think about what type of data is going to be important to collect as part of correlative analyses to build the most effective prognostic models. We're always going to have clinical data like tumor size or nodal status, but I think we'll see increasing use of language models to extract important data from health records, like comorbidity status or social determinants that may be predictive. What about the genomic data? We saw from Felsheimer and colleagues that it was the addition of RNA signatures to clinical factors that most improved prediction of survival. And this mirrors data that we've seen from other machine learning studies of early-stage breast cancer. Data from the TransNeo trial again found that it was addition of RNA features to clinical factors that most improved prediction of response to chemotherapy. Now, DNA sequencing is still going to be important, especially when we're considering treatment with targeted therapies against specific mutations, maybe in the metastatic setting where RNA signatures may be influenced by the site where you biopsy. And I think we'll see other features incorporated into genomic models, including protein expression-based assays or methylation profiles. What about TILs? Now that we have these accurate gene expression signatures, where will quantifying TILs play in? Well, I think going forward, we're going to see artificial intelligence play an increasing role in not just quantifying TILs, but identifying other factors on histology that may be associated with outcome. For example, in the study to the right, it was found that hemorrhage and necrosis on biopsy slides, in addition to TILs, predicted response to neoadjuvant therapy after an AI model was trained on over 500 cases of early-stage triple-negative breast cancer. Additionally, multiple studies have shown that we may be able to use artificial intelligence on histology to directly predict even individual gene expression levels. And maybe these kind of approaches could be applied to more broadly apply the findings from these genomic studies without a costly additional testing. And of course, we're going to see incorporation of other important biomarkers like circulating tumor DNA or radiographic imaging features into models. So in conclusion, we saw these two studies. Razavi and colleagues found that a clinical and genomic model more accurately predicted risk of progression on endocrine therapy with a CDK4/6 inhibitor. Now, this study needs to be validated. It's going to be important to make sure that the model is identifying true biologic features and not biases related to the single institution they trained the model on. However, I think that this approach could be successful and more accurately identify patients who need either treatment escalation or do well on standard therapies than our current definitions of endocrine-resistant disease. Felsheimer and colleagues found that stage and immune gene signatures can accurately predict survival for early-stage triple-negative breast cancer treated with chemotherapy. And they found that their model successfully had similar predictive accuracy in 3 external test sets. I think in the coming years we'll see whether this approach or others can combine clinical genomic features to improve risk prediction of early triple-negative breast cancer and identify the best patients for treatment de-escalation. So in both of these studies, we saw that machine learning, yes, can combine clinical and genomic factors to more accurately predict outcome than our standard decision tools. And I think as these approaches continue to be developed and applied, we'll be able to better personalize therapy and leading to better outcomes with less toxicity for all patients with breast cancer. With that, I'd like to thank the presenters for sharing their slides with me in advance of this talk, the organizing committee for inviting me to give this discussion, my colleagues at University of Chicago who helped with this work, as well as all of you for your attention.
And with that, I will thank again all of the presenters from this wonderful session and all of you for your excellent questions and engagement, and wish you well. Thank you.